नाम काट के लीला जोशी करना है इसको।
मैम आपका आवाज आ रहा है। जोशी मैम।
तेरी आवाज आ रही है बोल रहा है।
नहीं, आवाज तो आ रही है लेकिन
हाँ वो वीडियो
आप
नहीं आ रहा।
म्यूट कर दीजिए मैम।
एक 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 मिनट, अच्छा होल्ड कीजिए 1 मिनट के लिए।
ये प्रतिभा पांडे का नाम हटा दो, उसमें मेरी जगह उसका नाम लिखा हुआ है, इसलिए प्रॉब्लम आ रही है।
नहीं प्रॉब्लम को नहीं आ रही है। 1 मिनट, एक प्रॉब्लम नहीं आ
वही, जाम तो ऐसी चीजें कभी भी खा सकते हैं।
जो क्या हम रात को पता है जो खाना खाने के बाद
इंस्टेड ऑफ स्वीट।
दूध कोई भी कट होता है रात को।
मिस्टर नीलेश, आप कर सकते हैं ना प्रतिभा पांडे का नाम हटा के लीला
लीला
जोशी
जोशी
मैडम
कर दे,
का।
वो मेरी सिस्टर ने यूज किया था ना।
रही। ये आगे
हाँ हाँ
बैठ
ठीक है।
Hello, ma'am.
हाँ
हाँ
बैठ जा, आ जाएगा
Tirth,
तेरा।
Tirth here,
हाँ तेरा
but
बैठ जा।
I cannot change the name of
नहीं
person.
नो यू डोंट हैव टू। ओके हाँ
वो वाला लाइट
हाँ
ऑफ कर दे।
बंद कर।
सो सेल्फ करना पड़ेगा क्या
हाँ
नीलेश?
हाँ
ओके,
Will
I
not
tried changing her name, I could not, that's why I told you.
not required.
लाइट
Okay fine.
वाली ठीक
मैम
कर।
आदित्य here. हेलो मैम, जोशी मैम, गुड इवनिंग मैम।
हाँ, गुड इवनिंग, गुड इवनिंग। आई एम
गुड इवनिंग।
जस्ट एडजस्टिंग द
यस
लाइट।
मैम, मैम उसमें मैम पार्टिसिपेंट्स पे जाइए। मैम पार्टिसिपेंट्स पे जाइए।
हाँ, एक सेकंड।
मैम
नहीं
पार्टिसिपेंट्स। हाँ
डॉक्टर
हाँ
अदिति, वो ऊपर 3 डॉट्स आता है ना, उसमें ही
हाँ
चेंज कर
हाँ
सकते हैं।
हाँ जी मैम, पार्टिसिपेंट्स पे जाएंगे, मैम का नाम आएगा प्रतिभा पांडे, जहाँ लिखा होगा आप क्लिक करेंगे, चेंज नेम आ जाएगा।
वो लाइट जला तो देखो। अभी मेरा वीडियो
गुड इवनिंग मैडम, लीला मैडम, जोशी मैडम।
गुड इवनिंग, गुड इवनिंग।
नमस्ते चंदन मैडम, हाय ब्रिजबाला।
नमस्ते नमस्ते। गुड इवनिंग एवरीवन।
ये तो मैं ऑन कर दूंगी, पर वो इधर पिक्चर साफ तो आए, लाइट का ही प्रॉब्लम है।
जोशी मैम, आप लीव होके वापस ज्वाइन करेंगे ना, तो भी
हाँ,
ऑप्शन आएगा
तब
नेम
ठीक
का।
हो जाएगा। अच्छा, ठीक है।
हाँ मैम, तब नेम का ऑप्शन आएगा कि आप इसी नेम से ज्वाइन करना चाहते हैं या चेंज करना है, तब आप वहां पे चेंज कर सकते हैं।
नहीं, अदर देन दैट ऑन हर नेम, मतलब जो प्रतिभा का है ना, उसमें टॉप राइट में 3 डॉट्स आता है ना मैडम, वो क्लिक किए तो उस पर लिस्ट में लास्ट ई नेम आता है, आप उस पे उसके ऊपर क्लिक करके नेम कर सकते हैं आपको।
वहाँ पे लाइट जला के आऊँ कि जो बंद की हुई है उसी की।
हाय डॉक्टर मनीला।
Hello, ma'am.
I'm Rekha from Bangalore.
Yeah, ma'am. I know you.
Probably I'm
कैसे
the
मैम
only
आप?
one from South here.
Yeah, Dr. Brijwala, Dr.
हाय
Chandan
मनीला,
ma'am. Hello,
चंदन दीदी गुड इवनिंग।
Leela ma'am. Namaste.
हाय आराधना।
हाय,
Hi,
गुड
doc-
इवनिंग।
Hi, Dr.
Yeah,
Aradhana.
Dr.
Hi,
गुड
Aditi, Dr.
इवनिंग।
Aradhana. A very good evening to all of you. Jyoti Didi, hello.
हेलो हेलो ब्रज दीदी, रेखा।
हाय ज्योति, कहाँ
हाय
दिखती
hi,
नहीं मुझे।
Shani.
हाय चंदन दीदी,
Hi,
रेखा।
हाय ज्योति।
हाय
हाय,
ब्रज दीदी।
हेलो एवरीवन।
हाय हाय
Hello,
मनीषा।
Dr.
हेलो,
Manisha. Hi.
गुड इवनिंग।
Good evening.
दीदी बिलेटेड हैप्पी बर्थडे रिजवाला दीदी।
हाय मनीषा।
हेलो दीदी, मनीला। हाय,
Asha
Yeah,
Bakshi
hello ma'am.
madam, namaste.
नमस्ते जी, हाउ आर यू?
I'm fine.
गुड
Dr.
इवनिंग मैम।
Manik.
डॉक्टर आशा मैम,
Yeah.
गुड इवनिंग।
गुड इवनिंग।
गुड इवनिंग
गुड
मैम।
इवनिंग मनीषा,
Asha
गुड
ma'am.
इवनिंग मैडम।
Good evening ma'am.
आशा, ज्योति, मानिक,
नमस्ते।
लीला जोशी।
एवरीबडी हियर।
हेलो मानिक
चंदन।
Dr.
मैम।
Asha Jain has joined. Good evening
नमस्ते।
ma'am.
Namaste all. Dr. Sunita, Dr.
रेखा,
Aradhana,
रेखा
Dr.
दीदी,
Aditi.
रेखा फ्रॉम साउथ।
Yeah,
मैम।
the only one from South. Common factor.
नेहा।
Hello Neha.
गुड इवनिंग।
गुड इवनिंग, गुड इवनिंग एवरीवन।
Hi, Dr. Neha.
ज्योति, आप कहाँ गायब हो गए?
मैं कहीं गायब नहीं हुई दीदी। मैं कैसे गायब हो सकती हूँ?
ज्योति तो omni present है, omni present, omnipotent.
आशा दीदी और आराधना दोनों चाय पी रहे हैं।
नहीं पी रही हूँ।
अरे आई एम सो टायर्ड
अच्छा वो आशा दीदी।
राइट नाउ आई हैव ऑपरेटेड ओविरा सिंड्रोम एंड दैट वाज लाइक एमआरआई में था कि अंदर ब्लड कलेक्शन है, दैट वाज प्योर पस, थिक पस। तो इतना दिमाग आउट हुआ मेरा ना, जैसे इसमें निक लगाया पस एकदम फ्रैंक पस आना शुरू हो गया।
आराधना का दिमाग भी
डॉक्टर
out हुआ है क्या
श्वेता,
दीदी?
डॉक्टर श्वेता
हेलो मैम।
या हाय
नमस्ते।
श्वेता।
आपको इतना कॉल किया, आपने उठाया नहीं।
ये बंद कर दिया।
वीडियो ऑन कर दीजिए ना डॉक्टर श्वेता।
I'm just trying 1 minute.
ओके ओके।
हाय श्वेता।
ओ
मनीषा तो इतनी थकी हुई क्यों दिख रही है?
रवि
से आई हूँ बाहर
ये
बस
बंद
ज्योति।
कैसे होगा?
अच्छा,
इधर वाला करूं? ये इधर वाला करूं?
अदिति,
इधर वाला
अदिति खड़ी है क्या?
आशा मैम,
हाँ जी।
सॉरी मैडम, एक्चुअली मैं आज थोड़ा वो औरबिंदो तक गई थी, तब आपका फोन आना था, मैं मीटिंग में बैठी थी सबके साथ।
चलो कोई बात नहीं, मैंने एक मैसेज किया, उसको पढ़ के जवाब दो मुझे तुरंत।
वही मैंने आपको वो थम्स अप दिया था एक।
नहीं नहीं, मैं थम्स अप नहीं पूछ रही हूँ।
हाँ, सब पढ़ लिया मैंने।
नहीं, मैं अभी तुमको एक मैसेज कर रही हूँ, वो मुझे बताओ।
क्या आशा दीदी चुप के क्या मैसेज
Personal.
करते रहते हो?
अरे
पर्सनल
पब्लिक फोरम में पर्सनल मैसेजेस।
हाँ,
ऐसा है, मजा भी तो आप लोग को आना चाहिए, नहीं तो मेडिको लीगल पैनल में तो एकदम सो जाओगे।
अरे ऐसा मत
अपने
बोलो
ऊपर
यार।
देख
केस,
लिया मैंने, देख
अपने
लिया।
ऊपर केस नहीं आता है ना।
मैडम मेडिको लीगल पैनल में तो नींद उड़ जाती है।
हाँ आशा दीदी
नहीं,
ऐसे मत बोलो।
वही है ना।
हाँ,
ये होता है कि थोड़ी देर में
सो ही नहीं
आउट, यदि हम पे नहीं आई है तो हमें कोई मतलब नहीं। भाई मत सुनो, जितना सुनेंगे उतना डरेंगे।
नहीं ऐसा नहीं है दीदी, ऐसे मत
नहीं,
बोलो।
मैडम,
मेरी
बहुत डर
मेरी कमिटी है ये, इसमें किसी को सोने मत देना।
नहीं, मैं सोने नहीं दूंगी, बिल्कुल नहीं सोने दूंगी।
बहुत इम्पोर्टेंट कमिटी आशा जी।
हाँ
क्या मैम?
चंदन दीदी बिल्कुल सही बोल रही है।
हाँ, बहुत इम्पोर्टेंट कमिटी है, इसमें बिल्कुल किसी को मत सोने देना। भले ही चाय पिला देना, चाय पे चर्चा कर देना।
हाँ, रिचा क्या हालचाल? रिचा आज इतने जुड़ा उड़ा बांध के कैसे क्या?
क्या मैम?
इतना
Good
बाल
evening.
बाल बांध के कैसे क्या तू?
स्टोर रूम में बैठी हूँ मैं।
अरे
हाय
तेरे ऐसे दिन आ
रिचा।
गए।
तो नीचे स्टोर में
अदिति, हाय अदिति। Madam, good evening, everybody. Good evening from Jabalpur. I'm Dr.
Good
Richa
evening.
Tinawari.
Hi
Hi,
Richa.
Dr. Richa.
Good evening everyone.
डॉक्टर डॉली ने ज्वाइन किया क्या?
Hi, Neha. Good evening. Good evening,
डॉक्टर
ma'am.
डॉली नहीं दिख रही हैं। हाय आशा मैडम।
Hi.
Good evening all. Greetings from Bangalore.
हेलो मैम।
Hi, Dr. Monica.
Hello ma'am.
तीर्थ, आवाज चेक कर लो एक बार।
Good evening Asha Bakshi ma'am. Good evening
Yes,
Asha
ma'am.
Jain.
Already checked.
Okay, so you can stop sharing now. Let us have another couple of minutes of talk and then you can start.
Okay, ma'am.
अरे मैडम को तो कब
Patel
से
sir
लाइव
has
स्ट्रीम हो रहा
joined.
है।
Namaste sir.
सर हैज नॉट येट कम।
Sir has
Sir
come.
has joined.
Sir has joined.
ओके।
Dr. Dolly has not joined yet.
मनीषा।
नमस्ते सर।
अभी एक दिन गई थी दिल्ली, तो दिल्ली में आईएमए ऑफिस में गई थी, तो वहाँ सर का फोटो देखा तो मुझे बहुत अच्छा लगा। मैंने फोटो के नीचे फोटो अपना भी खिंचाया कि मध्य प्रदेश की शान है सर, उन्हीं का है फोटो मध्य प्रदेश में।
Thank
तो
you दीदी।
सर को मेरे रिगार्ड्स देना, है ना?
बिल्कुल दीदी।
कहाँ गई थी, कौन सा ऑफिस में आशा?
आईएमए ऑफिस।
हाँ, मैम,
आईएमए ऑफिस दिल्ली गई थी मैं, दिल्ली में।
हाय सुनीता।
तो मध्य प्रदेश से एक ही नाम था, वो सर का था।
हाँ मुझे ज्योति ने
तीर्थ
बताया था
लाइव
दीदी ये।
स्टार्ट कर दो।
Yes, ma'am. I have started YouTube
ने
live.
बताया था मनीषा को।
Okay,
बोला
now you
हाँ
can
ज्योति ने बताया था मुझे।
exactly 6 o'clock you can start.
Good evening,
Okay,
Patel
now I am
sir.
sharing it.
Yes, good
Sir has
evening. Good
joined.
evening.
गुड इवनिंग सर।
everybody.
सर।
Sir good evening.
बोलो,
Good evening.
बाहर से उठाने बोलो, मेरे को कुछ गुड़ या बता।
Thank you from MP side.
Yes, welcome, madam. Chandan,
Good
madam.
evening, sir.
Good
Namaste,
evening.
sir.
Good evening.
Good
Good
evening,
evening,
sir.
sir. Good evening.
Yes.
Ma'am,
Hello,
I'm
good
sharing
evening,
the
sir.
slides.
Good evening. Good evening.
अब तो जय श्री राम भी बोल सकते हैं.
बिल्कुल
जय श्री राम.
बिल्कुल.
हाँ.
आराधना तो पूरे दर्शन करके आई.
हेलो.
अच्छा.
Ma'am, can I start?
परिसर में क्या
Yes.
था?
She has sent
Hello.
you to yeah.
Asha, ma'am,
Yes, yes, please start.
can I start?
Oh, yes.
Yes, yes.
Okay, okay. Very good evening to present over here delegates and faculties. On the behalf of Corona Remedies Private Limited, I am Tirth Shah. Welcome you all in this Happy Learning Masterclass webinar series 188th edition in association with Indore, Jabalpur and Ratlam. And the theme of the today's webinar is mixed bag. So I welcome Dr. Asha Jain, convener of the today's webinar. Dr. Asha Jain is a past president of Raipur Obs and Gynec Society. She has a more than 32 years of experience. She has a Foxy recognized center of ultrasound training, colposcopy training. Currently, she is the director of SMSA Hospital Raipur, medical director of Cancer Prevention and Relief Society. She is a vice president of IMH Chhattisgarh, zonal chair Foxy Food, Drug and Medico Surgical Equipment Committee, West Zone. He is an executive member of ISCCP.
I think that's enough, Tir. These are all
Okay, ma'am.
my family.
Okay, ma'am. So as per our rituals, we will start our session with the prayer and lamp lighting session. So I request all of you to join this session. It is audible and visible?
Yes.
Yes.
Okay. Now I hand over this session to Dr. Asha Jain, ma'am. Asha Jain, ma'am, over to you.
Please stop sharing.
Okay.
Thank you, Tirthji. At the outset, I welcome everyone to this episode of Happy Learning Masterclass. And the director of this program is Dr. MC Patel, sir. And this is his brainchild. And it has been going on and on and on forever. So the consistency that he has in bringing this program together, hats off to him. And I request him to actually introduce the program and welcome the guests initially.
Yes.
Over to you, MC
Yes,
Patel.
thank you. Thank you, Asha. It gives me immense pleasure to welcome you all on 180th program of Happy Learning Masterclass web series. So today's joining society, Indore, Jabalpur and Ratlam. I welcome Dr. Leela Joshi, madam. She has kindly consented to be chief guest to bless the webinar. She is always with us in any of our academic activity, of any of our social activity. And whenever we call madam, she is always ready to bless us, to inspire us. So welcome, madam. One more chief guest, Dr. Jyoti Bindal, madam. She has also kindly consented to be chief guest to bless the webinar. Jyoti Bindal, madam, is also with me in any of my academic activities since long, and madam has kindly consented to be present today also. So welcome, Jyoti Bindal, madam. I also welcome two learned guests of honor, Dr. Asha Bakshi, past Vice President Foxy, and Dr. Kavita Singh, madam, from Jabalpur, past President of present President of MPOX and past President of Jabalpur OBGYN Society. Both have kindly consented to be guest of honor to bless the webinar. So welcome, Asha Bakshi, madam, and Kavita Singh, madam. I also welcome today's learned speaker, Dr. Dolly Mehra from Ratlam. She's going to talk about very interesting topic, ART pregnancy. Is it different, or it is to be managed same way as we manage any other pregnancy? So she is going to discuss very interesting topic today. And to chair that very session, 3 learned faculties are here. Dr. Manisha Maheshwari, past president of Ratlam OBGYN Society, Dr. Alka Agarwal, past president of Jabalpur OBGYN Society, and Dr. Sumitra Yadav, madam, president-elect of Indore OBGYN Society. They are going to chair this important session with their expert comment. I also welcome all the learned panelists who are going to ask questions, and being a moderator of this panel, I am going to answer. Dr. Sadhna Mehta madam from Indore, Sweta Kaul Jha madam from Indore, Dr. Dipti Gupta from Jabalpur, Dr. Manik Panse madam from Jabalpur, Aditi Rathod madam from Ratlam, Sunita Wadhwani madam from Ratlam, Dr. Neha Saraf madam from Ratlam, Dr. Richa Dhiravani madam from Jabalpur, Dr. Anupama Dave is unable to join, but she is always with us in any of our academic activity. Dr. Aradhna Gupta from Bhopal, Dr. Brajbala Tiwari from Indore, Dr. Kaveri Sopatel from Jabalpur, Dr. Monica Jindal Singh madam from Bhopal, and Dr. Manila Kausal Jain from Indore. And 2 experts are also there in that very panel, Dr. Chandan Paparia madam from Indore and Dr. Archana Basir from Indore. They are going to put their expert comments or remarks during panel discussion in any of question we are discussing. I also welcome Dr. Asha Jain, convener of this webinar. She is in this series since long as a convener. And I also welcome 2 coordinator, Dr. Jyoti Banglowala. She was coordinator in this series since long, and again she is back for this webinar. So welcome, Dr. Jyoti. I also welcome Dr. Rekha Rajendra Kumar from Bengaluru, president-elect Bangalore OBGYN Society. She is also in this series since long as a coordinator. So, and I welcome all the president and secretary of joining society, that is Indore, Jabalpur and Ratlam, and all the delegates who have joined this webinar. In era of COVID-19, when physical meetings were not possible, then we started this series, and with 3 friends, when I started, it was just to meet our Foxian friends on virtual platform when physical meetings were not possible, and to discuss any focused topic and to be helpful to our Foxian friend to update their knowledge. And with this, when we started, now I am happy to announce we are 7,000 plus member as far as Happy Learning Masterclass web series is concerned. And every time we discuss any focus topic, just I mentioned about today's topic, ART pregnancy and its management. And in this series, this is our 4th round. We have completed 3 rounds of all the Society of Foxy. This is our 4th round, and in 4th round, there is reverse panel. Panelists ask question, and being a moderator, I answer. And in this reverse panel, we discuss focus medico-legal issues. Say, for example, today's topic is medico-legal issues related to pregnancy, related to labor and its complication. So that way, we are running this series. And again, I am happy to announce it is 180th episode of Happy Learning Masterclass web series, with love, affection, and blessings and help, support of all of you. So we are running this program. So without wasting much of your time, over to you, Dr. Asha Jain. Thank you. Thank you very much.
Thank you, sir. Thanks a lot. May I have Dr. Jyoti's CV, please?
Asha madam, don't display CV. It's on my own platform, Didi.
So I welcome Dr. Jyoti Banglowala, who is the current chairperson of Medico Legal Committee, and she was on this platform for long, a dear friend. And what to say? I have to say something, Jyoti. Wait, I will share. So, I welcome Dr. Jyoti, who has 26 years of experience. She is the current chairperson of Ethics and Medical Legal Committee. This series of webinars was really helpful, I think. And she was the secretary of Indore Obstetric Gynec Society 21-22. Currently, she is the vice president of Indore Society. She's been part of all the conferences that Indore has held. She is the recipient of very many awards. She's published many papers. And I welcome you, Dr. Jyoti, to this program once again. I would also like to introduce the coordinator, Rekha Rajendra Kumar ma'am, who is the president-elect of Bangalore Obstetric Gynec Society. She's also been practicing for the last 32 years. And she is the chairperson of Ethics and Medical Legal Committee, Kasoga, currently, 23 to 25. Chairperson Infertility and ART Committee, Kasoga, 20 to 23. South Zone Coordinator, Foxy Infertility, 21 to 23. Many awards and felicitations, a PG teacher, many articles and case reports, a great dancer. Welcome, Dr. Rekha. And now I would like Dr. Jyoti to say a few words before we proceed with the program.
Good evening, everyone. Dr. MC Patel sir, Dr. Jyoti Bindal madam, Leela Joshi madam, Dr. Asha Bakshi madam, Kavita Singh madam, all my seniors, all my friends. Actually, it is the home platform for me, and the 180 number is such a great number. Actually, I greatly appreciate Dr. MC Patel for this continuity and this perseverance. And sir is a good communicator, and actually he helped me a lot to keep work in perspective. So before joining this Happy Learning, I was joining just to read about the high-risk pregnancies and all the things, and just listening and learning so many things about the medical legal. Many things are clear in my mind how to proceed in this committee, and even all the secretary and president of the Jabalpur, Indore, and Ratlam OB-GYN Society who have joined, and even Monica and Aradhna, you all know, even actually arranging a single webinar, how much pain we have to take, how much work we have to do, and this is a continuation of the 180 means 3 years, continuous 3 years, every Tuesday and sometimes Thursdays. Without failing any CVs, without failing any guest. The topics are excellent. So hats off to you, sir. And Asha madam and Rekha, they are the co-convener with me since long. And actually, when I worked for the Happy Learning series for 1.5 years, we had a good bonding. And actually, I was missing the thing. And when sir said about this MP webinar, I joined again. So thank you very much, sir, and the best wishes, sir, for all your endeavors. Best wishes, Asha madam and Rekha madam, for your all the endeavors, and welcome you all on the Happy Learning platform. Thank you.
Thank you, Jyoti. Thank you for all the help for this webinar and in past for this series also. I would like to mention about Jyoti. Jyoti is heading the same committee, Ethics and Medical Legal Committee, FOXY, which I headed long back. So she is my successor as far as this committee is concerned. And she has also started working for that very committee very positively and very actively. She has started physical meetings, she has started webinars, and I am quite hopeful she will put this committee to such a height that we can appreciate that Jyoti has done the justice to her post. So thank you, Jyoti.
Thank you, Dr. Jyoti.
Thank you, sir. Thank you, Dr. Jyoti. Dr. Rekha, a couple of words from you also, and then we invite the guests.
Thank you, Dr. Asha, for the opportunity. We all have been working for this Happy Learning webinar series under the leadership of Sir Dr. MC Patel, sir. And before we joined also a few years back, sir has been doing since COVID times all this. And as Dr. Jyoti said, we know how difficult it is to put many things all together. Once the program is finished, like today, sir will be ready from the next minute for next event. That is the next Tuesday. And without fail, we have been doing so many programs, and majority of the task is taken, the responsibility is taken by sir. And sir does lot of work in right from collecting the CV phone numbers and making the WhatsApp group, and lot of effort that he makes it easy for us also to work for us. Other than the academic interest, sir has lot of philanthropic work which he does without anybody's knowledge in the northeastern part of India, where every year, sir, at least for a week, he does lot of work, the social service for the privileged people, the downtrodden people, and that is another face of sir. Thank you so much, sir, for all your commitment to our society as well as the Foxians. I'm very sure all the post and the consultants like us are very much benefited from your so much of academic effort, because lot of very not only the medical legal issues, you cover so many variety of other topics also, so that PGs can take the exam without much effort if they listen to your programs, and they also get the ready-made YouTube video even if they miss the program for some reason. Thank you so much for taking us as a part of your core program. I also welcome all the dignitaries who have made time and for your august presence here. Thank you, one and all.
Thank you. Thank you, Rekha.
Yeah.
Thank you, sir. Thank you, Dr. Rekha and Jyoti. Now we will start the inaugural program. It is a great pleasure and privilege to invite Padma Shri Dr. Leela Joshi ma'am, who's MD FICOG DGO, and is also recognized. I would not like to say that. I think she's much beyond that. So she doesn't convert. So welcome, Leela ma'am. And she's retired as Chief Medical Director, Indian Railways 1996. She's settled in Ratlam, a tribal district of Madhya Pradesh, for her mission to reduce maternal mortality in these underprivileged areas by eradicating anemia. And she's still continuing to do that at the age of 84 years. Being in a transferable job, founded 3 branches of Foxy at Kota, Dehradun, and Ratlam. Some of her honors and awards are: she's a Padma Shri, one of the 100 Women Achievers, Women Pride Award, Vishwa Seva Ratna Award, Pride of Foxy Award, Artist Reality Award, and Distinguished Community Service Award, and many, many more. So welcome, ma'am.
Namaskar.
We would love to have a few words of blessing from you.
Our today's chief guest, Dr. Bindal, guest of honor, Dr. Asha Bakshi, Dr. Kavita, and the convener. She is so busy phoning everyone, the coordinators, all the speakers, the chairpersons, the panelists, and all my friends of Ratlam, Jabalpur, Indore, and all other friends of Foxy, and overall, Dr. MC Patel. I personally feel that just this 180th edition of this master classes, this is simply wonderful. I personally feel that the word congratulation is much less for that, for its continuity. I salute you.
Thank you. Thank you.
And its continuity, and the other beauty, I find that it has penetrated so down and so wide, this thing. I think none of the Foxy branch and none of the Foxy is unaware of the things and had full benefit of the way the knowledge has been spread. And the connectivity, we feel so much together because of all these things. And I thank you, Dr. Patel, for making me a part of this wonderful event, this wonderful series, in fact. And without taking much time, I feel I very sincerely give my all the best wishes for this today's webinar, and also for the many to come subsequently. Thank you so much. Thank you very much. Thank you to each and every one of my friends present here. Thanks.
Thank you. Thank you, madam, for sparing time to bless us. Of course, you are always with us.
Dr. Rekha?
Yeah. Thank you, Dr. Asha. Again, it's another privilege and a very good opportunity for us. And we are so honored to introduce Dr. Jyoti Bindal, Madam. Madam is the Vice Chancellor of the university, that is Sri Aurobindo University, Indore. She has many achievements and associated to many important institutions. She has received Dr. J.G. Jolly Oration Award in 2021 by National Academy of Medical Sciences, Foxy Shiromani Award in 2020, Strategic Advisor and Member, Access Committee of BTA UK, member of the COVID Training Advisory Committee, and also the PCPNDT Committee. Madam is the member of the state as well as the district level. She was the ex-president of Association of Madhya Pradesh OBG Society, ex-dean of Medical College, Mahatma Gandhi Medical College, Indore, ex-director of Gwalior Mansik Arogya Shala. Madam is also ex-member, Core Committee, National Human Rights Commission. Thank you, Dr. Jyoti, Madam, for your esteemed presence here. We are really happy and honored to have you here. Would you mind telling us few words and give your blessings to us in this forum, Madam?
Thank you so much, Rekha, for such glowing words and introduction. Honorable Leela Joshi, ma'am, it's an honor to be sharing the platform with you. I've always watched your gracious presence and remarkable work which you have put in for the society. I have no words to share my feelings for Dr. M.C. Patel. I think, sir, I came to know about you when you were heading Medical Legal Committee, and I remember being a member of your committee in the first instance, and that's how, because being a law graduate myself, medical legal has been always my field of interest. And I mean, crazy master series, sir, 7,000 members, but 70,000 people who have benefited, more than that. So you've really been doing amazing work. And you already know that I'm such a big fan of yours. You should have gone in for presidency much earlier. I don't know why you delayed it so long. Once again, Jyoti Banglowala has become a very dear friend. She's so enthusiastic, bubbling all the time. It's a pleasure to work for you, Jyoti, anytime you say.
Thank you, Madam. Thank you very much.
And sir, I don't want to, spend too much of time because everybody's so keen to hear about the lectures today. We are keen to hear about your medical legal aspects. As always, in every webinar of yours, this great input is something we look forward to. And once again, thank you so much for having me here, and all the best, sir.
Thank you. Thank you, madam. You are always with us in any of our academic activities. And I still remember my visit to Gwalior when you were president of Gwalior OBGYN Society. And we had a full day workshop related to medical legal issues in OBGYN.
Absolutely, sir. Absolutely. And your visit in Indore also, when you came to my home.
Since then, our bond of relationship is getting stronger and stronger day by day. Thank you, madam. Thank you. Thank you.
Thank you, sir. Thank you, Jyoti ma'am. Dr. Asha Bakshi, ma'am, are you there?
Yeah, she's there.
No. She is logged in, but is she there?
She is there.
Ma'am, are you there?
हाँ मैडम है वहाँ पे हैं.
उन्होंने अभी मैसेज किया that she has to go for an emergency. So ma'am is the past vice president of Foxy, immediate past president, vice president of Foxy. Currently she is secretary ISAR, member of executive committee AICC RCOG West Zone, founder chairperson MP IAG and MP ISAR, member of advisory committee of PCPNDT Indore. He was the chairperson Foxy Infertility Committee 2017 to 19, ICOG Governing Council 18 to 20, past president IOGS, vice president 2022 West Zone Foxy. She has, to her credit, first ICSI TESA and ICSI and Micro TSE ICSI babies of Madhya Pradesh, recipient of Dr. Kumud Tamaskar Award, FOXY 2008 and 9, best paper in the journal 2011-2012, Padma Shri Dr. S.K. Mukherjee Award 2021, Excellence Award Dainik Bhaskar 2021. She has organized the Star Endogen 2019, organizing chairperson AICOG 2022, and New Age Obstetric Gynec Conference 2023 in Indore. Over to you, Asha ma'am. She just messaged that she had to go for an emergency.
No issue. We can proceed further.
Yeah.
And when she comes again, we'll
Dr. Rekha, would you take this?
Yeah, fine. Yeah, thank you so much, Dr. Asha. Again, I'm happy to introduce another guest of honor, that is Dr. Professor Kavita Singh. Madam is MS PhD, that too in Gynec Oncology, FICOG, FICMCH, Professor and Head of the Department of Obstetrics Gynecology, NSCB Medical College, Jabalpur, former trainee and fellow of Gynec Oncology. Madam's special interest is in oncology. WHO Master Trainer of Colposcopy, President of Association of Gynec Oncologists of India, Madhya Pradesh Chapter from 23 to 25, President of Association of MP Obstetrics and Gynecological Society, 23 to 25, International, National and State Awards more than 20, publications more than 40, as well as she's an undergraduate as well as postgraduate teacher for more than 2 decades. Madam, Dr. Professor Kavita Singh, we would like to hear from you, Madam.
Good evening, dear members, all the dignitaries on the dais.
Yeah.
At the outset, I would like to congratulate Program Director Dr. Patel, sir. Am I audible?
Yes, you are audible, madam.
Yeah, so
yes, madam.
Regards to you, sir. My humble regards to Madam Joshi and Madam Bindal. And it's nice to see Jyoti and Rekha managing the program, and Dr. Asha Jain, my co-guest of honor, Dr. Asha Bakshi. I extend my greetings from state of Madhya Pradesh as a President MPOX, and I wish good luck to you, sir. And I'm really happy to see all my friends from Jabalpur, Indore, and Ratlam. You have literally picked up all the stars in this Core Connect, sir. So my best wishes to all of you, and I pray that tomorrow is Vasant Panchami, so my regards to Ma Saraswati, and with this, I wish you all the very best. Thank you so much. Thank you for inviting me. Thank you so much.
Thank you, madam, for sparing time to bless us. Of course, you are always with us in any of our academic activity. Thank you, madam.
Kavita, madam.
Dr. Rekha?
Yeah. Thank you, Dr. Asha. And now we have finished the inaugural ceremony and we are starting the academic session, dear faculties. Can I have the CV of the chairpersons? Yeah, thank you. We have 3 chairpersons for a talk, and the talk is by Dr. Dolly Mehra. Pregnancy, is it different? I request the chair.
Dr. Rekha cannot be heard. I think there's been some problem.
Connection
So, Dr.
loss.
Manisha, yes, sir. Dr. Manisha Maheshwari, ma'am, who's MBBS MS consultant, Maheshwari Hospital, Ratlam, honorary consultant, Divisional Railway Hospital, Ratlam, and she was the president of Ratlam Obstetric Gynec Society 2020 to 2022, a very gentle person. We also have Dr. Alka Agrawal, ma'am, who's an MBBS MD, President Jabalpur Gynec Society in the year 2020. Past President Jabalpur Obstetric Gynec Society 19 to 20. Currently, she is the President of Jabalpur Menopause Society up to the year 2025. Organizing Secretary of FOXY West Zonal Conference with Yuva. Tirth, would you please mute everyone else? recipient of National Award for Pradhan
Okay,
Mantri
sure.
Surakshit Matritva Abhiyan, Pledge for 9 Achievers Award, Vice President IMA Jabalpur Branch 2022 to 23, and she's a faculty at national and zonal conferences. We Dr. Sumitra Yadav ma'am may not be able to join because she is in a meeting with the collector and she messaged me. She has a teaching experience of 33 years. She is the organizing scientific chairperson AICOG 2022 and workshop in charge AICOG 2022. She has many awards. There's a lot of disturbance. Who is speaking? There's a lot of disturbance.
Yeah, Dr. Asha, go ahead.
Yeah, there's too much of disturbance, means I can barely speak. So she has HIV Utkrishta Seva Award, Nari Shakti Award by Brajbhumi Foundation of Hema Malini on September 13, 2019. Nai Dunya Naika Award, winner of Dr. C.S. Dawn Award for Best Paper Presentation, Young Scientist Award, awarded 13 times for exemplary services in HIV/AIDS in pregnant women by District State Award of Karnataka, CBSE, National Topper 10th and 12th. A very accomplished lady, currently the professor and HOD, Department of Obstetrics and Gynecology, MGMMC Indore and MTH Hospital. So over to you, respected chairpersons, to take the program further. I would request you to introduce the speaker, Dr. Dolly Mehra.
Thank you, madam. At the outset, I would like to thank Dr. MC Patel, sir, for having me here in midst of stalwarts of MP and Foxy. And today is my privilege to introduce none other than my colleague, Dr. Dolly, who is a shining star, dynamic and daring obstetrician of Ratlam and MP. She is consultant obstetrician gynecologist in Mehra Nursing Home, President Ratlam Obs Gynae Society, Ratlam Obs Gynae Society from 2014 to 19, organizing chairperson of MP State Conference MPOX in 2018, zonal coordinator Foxy 1920, joint secretary MPOX 2019 till present. She is faculty in various national and state conferences, author and various obstetrics and gynecological books, and peer reviewer for Jogi. She received many awards, to name few: Champions of Foxy Award, Foxy Dr. Duru Shah Youth Trophy Award for Best Activities in Adolescent Health to Ratlam OBGYN Society, felicitated by Health Minister of MP for providing services under PMSA Scheme 2019, Wonder Foxian Award 2019, Champions of Foxy President Appreciation Award to Ratlam OBGYN Society under her leadership in 2019, Nari Swasth Pahal Foxy Appreciation Award at AICOG 2018, Special Appreciation by Foxy Adolescent Committee, Foxy Public Awareness Committee in 2016 to 18, and she has a special interest in high-risk pregnancy, infertility, and vaginal surgery. I welcome and request Dr. Dolly to please come over and deliver her talk on ART pregnancy. Is it different? Welcome, Dr. Dolly.
Requesting Dr. Alka Agrawal ma'am to please introduce the topic while Dr. Dolly will share her slides. Alka ma'am, you are muted.
Yes. Good evening to all the stalwarts and all the members. I'm so thankful to Dr. MC Patel for giving me this opportunity to be a part of this wonderful program. And today's topic is how ART pregnancy is different. So ART pregnancy is certainly different. Actually, it is conceived in a dish, and the normal pregnancy conceived in bedroom. But still, there are differences. Like most of them, they are similar, but there are different things. Like the indications for ART pregnancies are different. Generally, elderly primary. These patients are elderly primary, so they will have all the complications of elderly primary patients. Then they may have comorbidities because they are conceived in this ART is done generally in elderly group. So they will have comorbidities like diabetes mellitus, hypertension, SLE, etc. Then there are high chances of ectopic pregnancy in these conditions and abortions and multiple pregnancies also. So they will have complications of multiple pregnancy also. They can face that also. Then there are increased chances of PIH, increased chances of IGR, and increased prematurity. And sometimes they are actually, they should not end up in cesarean more than the normal pregnancy, but because of the indications, these ART pregnancies are different than normal pregnancy. Now, I invite Dr. Dolly Mehra to tell us about the ART pregnancies. Dr. Dolly Mehra from Ratlam.
Thank you so much, respected chairpersons, Dr. Manisha Maheshwari, Dr. Alka Agarwal, Madam, Dr. Sumitra Yadav, Madam. First of all, thank you, Dr. MC Patel, sir, for giving me this opportunity. And thank you to Dr. Asha Jain, Dr. Jyoti Banglowala, and Dr. Rekha for giving me this opportunity. With deep and great regards to my own inspiration, Dr. Leela Joshi, Madam, whom I observe daily, and Dr. Jyoti Bindal, whom I observe remotely. Regards to the guest of honor, dynamic Dr. Asha Bakshi, Madam, and my own MPOX President, Dr. Kavita Singh, Madam. So to start with today's topic, ART pregnancies. Are they different? So let's go ahead and see whether they should be treated as precious pregnancies or not. ART pregnancies, assisted reproductive technology, now accounts for 1.6% of all infants and 18.3% of all multiple births infants in United States. IVF is associated with several maternal and perinatal outcomes. Nearly one child in every class has been born after ART treatment in urban areas. In India, around 2 to 2.5 lakh IVF cycles are undertaken in a year. So imagine the amount of ART pregnancies which we come across in nowadays. So why are the ART pregnancies high risk? Because of maternal age, pre-existing comorbidities, causes of subfertility itself can cause a high-risk issue, IVF procedure, and previous surgeries like myomectomy or any other procedure which can make these pregnancies high risk. Now, what are the challenges? ART can elevate the burden of infertility on individuals and family, but it can also present certain challenges like high rates of multiple deliveries, preterm deliveries, and low birth weight deliveries. There can be obstetric complications. Increased risk of obstetric complications from ART appear to apply to twin gestation as well as to singletons. So not just twins, even the singleton pregnancies are at risk. When compared with non-ART dichorionic twins, the ART neonates had an increased risk of preterm births, very preterm births, and congenital malformation. So various issues, various maternal risks which can arise are miscarriages or ectopic, 15% in women with less than 35 years of age, 25% in women more than 35 but less than 40 years of age, and 35% in women above 42 years of age. There can be multiple pregnancy, which can lead to abortions, gestational hypertension, placental abruption, and previa. There can be increased rate of intervention like induced labor, elective LSCS, and there can be psychosocial impact as well. Now, there are various fetal risks also involved in these ART pregnancies, like chromosomal anomalies, de novo chromosomal abnormalities in IVF-ICSI babies for male factor infertility, aneuploidy in pregnancies adapted for maternal age and number of fetuses, multiple births, which again causes prematurity, low birth weight, and neonatal morbidity and mortality. So what is the best way? The best way to protect the mother's health and that of the baby, regardless of how the pregnancy occurs, is good antenatal care, which we should emphasize. Is there a standard protocol? No, there is still no standard protocol to follow these ART pregnancies. What antenatal care we are going to provide? So we should continue the progesterone support. How long? Individualized according to every patient profile. Progesterone is relatively safe and therefore can be continued till 12 weeks of pregnancy. Micronized progesterone vaginally is the drug of choice. Folic acid supplementation should be continued. Thyroid medication, if she's on it, she should continue. And she should continue the medicines which are prescribed by the ART consultant. Routine blood tests, along with that, additional blood tests, case-specific blood tests, rule out hemoglobinopathy. The most important thing is continuity of care in the antenatal period. It should not be that the ART consultant takes care of the patient till 3 months and then the patient doesn't take any other antenatal visit and then reaches to the obstetrician in the 3rd trimester. So there has to be a continuity of care in the antenatal period, and there should be clear referral paths if at all they are required. In the early pregnancy, management of OHSS, if it occurs, is important. You should monitor supportive therapy, maintenance of intravascular volume, prevention and treatment of complications, and counseling regarding the signs and symptoms of OHSS is important. Management can be in the form of outpatient care and inpatient care. Outpatient care in the form of limited activity, waked daily, input-output charting, daily follow-up, report if the symptoms worsen, and if there is a weight gain of more than 2 pounds per day. Inpatient care in the form of ICU care, vitals every 4 hours, daily weight and AG, hematocrit and TLC monitoring, serum electrolytes, renal function, liver function, PT, APTT, and watch for renal function, ARDS and DIC. This should be done in the early pregnancy. Now, once this part is over, what has to be done at around 6 to 7 weeks? A dating scan is very important. Rule out ectopic and heterotropic pregnancy. Remember, you have to rule out heterotropic pregnancy as well in these pregnancies, which is very uncommon in natural conception. Check for viability. Check for whether it is single or multiple pregnancy. If multiple, then check for chorionicity. The rate of miscarriage is slightly higher than in the spontaneous pregnancy, maybe because of the older maternal age. Ectopic pregnancy, approximately 0.7% of total ART cycles result in an ectopic pregnancy. The risk of ectopic pregnancy after ART procedure depends on the type of procedure like ZIFT, the indication of ART treatment, higher with tubal factor infertility, and estimated embryo implantation potential. Lower risk is seen in ICSI pregnancies than IVF pregnancy, and lower risk is seen in ovum donation and surrogacy. Multiple births, major complication of IVF is a risk of multiple pregnancy. In natural conception, 1 in 80 pregnancies are twins, while in ART, 1 in 5. And also, higher order births are common with ART, which is very uncommon in the natural conception. This is directly related to the practice of transferring multiple embryos at the ET. Can we prevent multiple births? Strict limits on the number of embryos may be transferred in some countries like Britain and Belgium to reduce the risk of higher order births, but this is not universally followed and accepted. Spontaneous splitting of embryos in the uterus can occur, but it is rare. Maternal age 38 to 40 years, you transfer more than 1 embryo is acceptable. Therefore, optimum number algorithms need to be decided based on further clinical research. Vanishing twins. If IVF twins are more common, in IVF, twins are more often conceived than born. Most vanish in due course of time. Still, the true incidence of vanishing twins is difficult to assess. According to one data, it was estimated that approximately 30% of these twins ultimately result in singleton, and less than 10% will end in a complete abortion. So in multiple pregnancy, our aim should be prolongation of gestational age, increase in the fetal weight, improve the perinatal mortality and morbidity, and decrease the incidence of maternal complications. So multiple pregnancy, the ANC should be a consultant-led team. Embryo reduction in high order multiples gestation is preferable after 11 weeks. But this is, it's like, first of all, we make them conceive with 3 fetuses and then we reduce it. So it is a secondary prevention. We should go in for primary prevention. There should be visits every 2 weeks. Iron folic acid supplementation should continue. Cervical length assessment should be done, and careful watch for complications should be done in all multiple pregnancies. There are many maternal risks involved with multiple pregnancies, which we all know of. There are various fetal risks also involved with multiple pregnancies, but they should be taken care of by a watchful expectancy. What do you do if there is a single twin demise or if there is fetal reduction? So a baseline coagulation profile for mother, watch for preterm labor, counsel regarding the prognosis of second twin. There is a chance 17% risk of neurological damage. Early delivery is not warranted and cesarean section is not indicated in such situation. Once we cross the first trimester and we reach the second trimester. So what antenatal care at 12 to 13 weeks? NT scan and soft tissue markers, that is double marker, the combined test should be done. Need for fetal reduction should be discussed with the patient. Check for vanishing twins. Check for cervical length if there are multiple pregnancies. And the need for chorionic biopsy and NIPT should also be discussed with the patient. At around 18 to 20 weeks, anomaly scan or the target scan is important. Quadruple marker test if double marker has not been done. Cervical length assessment, NIPT, amniocentesis, and here fetal echo at 22 weeks is also indicated. So are congenital malformations increase in ART pregnancy? A meta-analysis demonstrated association between IVF-ICSI and congenital malformation, although it remains unclear if this association is due to infertility, factors associated with the procedure, or both. It is difficult to distinguish the risk associated with IVF alone versus IVF with ICSI. Therefore, a detailed obstetric ultrasound should be performed in all ART pregnancies. What are the reasons for congenital malformation? Increased maternal age, oocyte and sperm abnormalities increase with increasing age. It is also seen that more the number of oocytes in stimulated cycle, higher is the incidence of aneuploidy. ICSI in male factor infertility, leading to transmission of genetic causes such as Y chromosomal microdeletion, ultrastructural sperm defects with genetic basis. Embryo is exposed to mechanical, thermal, and chemical alteration, which theoretically increase the risk of malformation. Genomic imprinting involves alteration of gene expression by methylation and histone modification of alleles from one parent so that either maternal or paternal allele is expressed without changing the genetic sequence. Increased risk of imprinting disorders like Beckwith-Whitman syndrome and Angelman syndrome is seen. Cryopreservation can theoretically increase the risk. Now, a recent database involving 3 lakh births found that ICSI pregnancies had a greater risk of congenital malformation compared to IVF. No difference in ICSI using ejaculated sperm, testicular sperm, or epididymal sperm. Babies born after fresh ET have greater anomaly as compared to frozen section. Here, because it is said that the embryos, the normal embryos, they withstand the thawing and the freezing process. And the abnormal embryos, they do not withstand this. Hence, it is seen that babies born with fresh ET have greater anomaly as compared to the frozen ET. Musculoskeletal, urogenital abnormalities, cleft palate, esophageal and anal atresia are increased in babies with ART. Chromosomal abnormalities are more with severe male factor as well as female subfertility. Is CHD risk increased in ART pregnancy? Several studies report higher rates of CHD in IVF-ICSI pregnancies as compared to naturally occurring pregnancies, while other studies report that the incidence of CHD in IVF pregnancies without other risk factors is not significantly different from baseline population. Fetal echocardiography should be offered to patients with IVF-ICSI, and this is a grade 2C recommendation. Further, as we move in the pregnancy, screening for gestational diabetes, preterm labor, preeclampsia, placenta previa, asymptomatic bacteriuria, and chlamydia screening should be done. HDP, a cohort study of over 5 lakh women was done to determine the risk of HDP in women undergoing ART compared with women with natural conception. And after adjusting the maternal age, interbirth interval, new partner, women undergoing ART had a small increase in odds of preeclampsia in second and third pregnancies compared with women with natural conception. PIH in ovum donation cycle, in a meta-analysis of 19 studies, they compared the risk of preeclampsia and HDP in pregnancies conceived via ovum donation, other ART, and natural conception. Pregnancies with ovum donation had a more than double risk of preeclampsia when compared with other ART methods and more than 4-fold increase compared to natural conception. This should be borne in mind. Low-dose aspirin prophylaxis. United States Preventive Service Task Force do not recommend low-dose aspirin in an IVF pregnancy as the sole indication for preeclampsia prophylaxis. However, if one or more additional factors are present, then low-dose aspirin is recommended, which is a grade 1B recommendation. PROM, 2 systemic reviews and meta-analysis show that probability of PPROM is significantly increased after ART compared to spontaneous, both in singleton as well as multiple births. Spontaneous preterm delivery, a meta-analysis of singleton pregnancies demonstrated that IVF is associated with higher odds of preterm birth as compared to naturally occurring pregnancy. Preterm birth is associated with various neonatal complications like encephalopathy and perinatal mortality. Such risks are more than double in presence of IVF twin pregnancies. Subfertility is a major risk for prematurity. Visualization of cervix at 18 to 22.6 weeks of gestation by transabdominal or transvaginal ultrasound is not recommended as a routine for IVF pregnancy. But if there is a risk factor like multiple pregnancy or previous history, then it has to be done. Progesterone supplementation initiated for IVF cycle is not indicated after 12 weeks of gestation if it is solely for the IVF purpose without any other indication. Fetal growth restriction. An increased risk of small for gestational age is documented for singleton IVF pregnancies. Meta-analysis have been described a higher risk of SGA babies and IVF ICSI pregnancy from fresh cycles compared with frozen cycles. Assessment of fetal growth restriction in 3rd trimester for IVF should be kept in mind. However, serial growth ultrasounds are not recommended as a sole indication of IVF. In 3rd trimester, close monitoring for fetal growth for preterm labor, special attention for placenta previa and adherent placenta, and steroid administration should be undertaken. Various placental abnormalities are also seen. IVF pregnancies are associated with higher risk for abnormal placental shape, placenta previa, marginal or filamentous cord insertions, and placenta accreta spectrum compared to naturally occurring pregnancies. So careful examination of placental location, shape, and cord insertion should be performed at the anomaly scan. Stillbirth, a national cohort study from Denmark of low ART pregnancies reported a stillbirth rate of 0.1% following IVF and 0.3% after ICSI. For low-risk patients, it is not known if the increased stillbirth risk is related to the treatment or to the underlying subfertility. Pregnancies achieved with IVF have a 2 to 3-fold increased risk of stillbirth even after controlling for maternal age parity and multifetal gestation. Weekly antenatal surveillance beginning by 36 weeks of gestation for pregnancies is indicated in IVF pregnancies. Timing of delivery in IVF pregnancy, it is currently unknown whether elective delivery at 39 weeks reduces the risk of maternal morbidity and improves the perinatal outcome. Hence, in absence of studies focus especially on the timing of delivery of IVF pregnancy, it is recommended to have a shared decision-making between patients and healthcare providers when considering induction of labor at 39 weeks of gestation. Perinatal mortality. Perinatal mortality appears to be increased as much as 4-fold because of obstetric complications, LBW, and multiple gestations. So to improve better use of infertility modalities, early diagnosis of twins, prevention of preterm birth, close fetal surveillance, and atraumatic labor and delivery is indicated. LSCS on demand or Muhurat LSCS, I would like to ask this question to our own expert, MC Patel sir, after my talk. Postpartum care, it is very common to see puerperal psychosis in these patients should be taken care of. Lactation problems, monitoring for comorbidities, and neonatal care should be explained to these patients. Maternal morbidity, when the same data was analyzed for antenatal hospitalization, women with ART pregnancies had an increased risk of antenatal admissions and longer hospitalization compared with non-ART pregnancies. Severe maternal morbidity in a cohort study that used propensity score matching and control for multiple factors, including maternal age, multiple gestation, IVF was associated with nearly 40% increased risk of severe maternal morbidity compared with spontaneous conception. PPH, ICU admission, sepsis, are the most common indications for severe morbidity. Psychosocial issues also have to be dealt with. If there is we do a fetal reduction, if there is death of one twin, frequent ultrasound monitoring, anomaly in one fetus, preterm delivery, financial burdens, and job worries also have to be tackled by the obstetricians. So counseling becomes very important. Counseling before IVF regarding worsening of the pre-existing medical condition, increased risk of chromosomal abnormalities, risk of multiple gestation, risk associated with advanced maternal age, psychological and psychosocial impact should be discussed. At the same time, preventive measures by the obstetrician should be undertaken. Counseling during ART, counseling regarding all complications during pregnancy should be done. Correctly calculate the EDD, monitor cervical length in multiple gestation, and intense monitoring of monochorionic twins has to be done. Medico-legal issues, of course, it is going to be taken care of by MC Patel sir. In case of failure to diagnose twins, frequency of tests, late detection of growth problems, and wrong estimation of gestational age. There are certain long-term issues as well. In a study comparing 253 ART conceived adolescents with case match controls, there was no detectable difference between the groups for general health, mental health, cognitive ability. However, larger cohort studies are required to confirm this. Cancer. A systemic review and meta-analysis including 25 case control and cohort studies reported an association between fertility treatment with ART and cancer in offspring. But I've taken this aspect after the counseling because more robust and larger studies are required to, so that we can discuss this with the patient. There is increased risk of all cancers, hematological cancers, solid cancers, leukemias, neuroblastomas, and retinoblastoma. But still, a robust study and a longer study is required to discuss this. There are certain psychosocial concerns also, like overprotective parenting and unrealistic expectations, non-disclosure of the genetic origin and gamete donation, as disclosure might disturb the parent-child relationship. Non-traditional families like solo mothers and lesbian donor mothers may develop behavioral and emotional problems, and surrogacy families, they have their own issues. So to end, the take-home message is, little is known about the ideal monitoring of patients who conceive after IVF treatment. All conceptions, remember, all conceptions should be considered precious, whether natural or assisted. It is responsibility of clinician to monitor ART pregnancy appropriately and not overtreat by labeling these pregnancies as precious. At the same time, realizing that complications can occur, early detection and management is warranted to ensure desired outcome of healthy mother and a healthy baby. Thank you so much.
Thank you, Dr. Dolly. That was very, very good. Said everything without really saying anything because there are still no guidelines.
Yes.
So over to you, Alka ma'am. You are muted. You are muted.
Yes. Thank you, Dr. Dolly Mehra, for the wonderful and very detailed, informative talk on this subject, ART pregnancies. And I think you have said that the counseling before ART, after ART is very much necessary, and patients should be taken in consideration, and they should know that what they will go through after having this ART pregnancy. They may have multiple pregnancy. If comorbidities are there, that can be increased, and then as you have said, many complications like abortions, ectopic pregnancy, premature rupture of membrane, prematurity, and they may end up into cesarean section, and post-operative also psychological problems can occur. So I think they should be well counseled, and on every point, the proper antenatal care is very much required to deliver them safely. So thank you very much, Dr. Dolly.
Thank you, ma'am.
Dr. Archana Basir ma'am has joined in. Archana ma'am, I just saw her. Archana ma'am, would you like to add something? Chandan ma'am, would you like to add something? Sir, Sumitra ma'am bhi aa gayi.
Yes, Sumitra madam can also have her comments.
Anybody has any questions on this?
Dr. Asha, no
All the-
questions. Just in the one slide, it was like progesterone supplement till 12 weeks of gestation, but actually we continue it till late in the trimester. So that is one additional point. Otherwise, excellently covered by Dr. Dolly. Thank you.
Thank you, ma'am.
Yes, it
Thank
is
you, Dr.
right.
Kavita. Thank
Because,
you.
few of our friends continue up to first trimester, few up to 20 weeks, and few up to 32 weeks. So it depends upon the practice prevailing in that very area.
So here I would like to ask one question, sir. That
Yes.
if suppose, because the guideline says that you continue till 12 weeks, beyond that it is not needed. If suppose the patient goes into preterm labor and we have stopped the progesterone at 12 weeks, what medical legal issues are we going to face?
If we have followed standard guideline given in standard textbook or practice prevailing in nearby medical college or standard guideline by ICOG, FRCOG or any other standard institution, then we are saved in court of. Because whenever we treat any patient as per standard guideline, it shows our concern that we have managed that very patient as per standard guideline.
Sir, actually here the catch is that there is nothing standard here. That is the basic thing, because when you say that every patient of IVF pregnancy has a higher chance of preterm labor, one of the ways you can prevent preterm labor is by giving progesterone, which we find is as effective as a cerclage.
Yes.
So in that case, you may need to stop that progesterone in the needs of a routine, luteal phase support or a corpus luteal support that you are giving. For that, you will stop the progesterone, but you can always continue it to prevent preterm labor in the future. So I hope that answers your question, Dr. Dolly.
Yeah.
Sir, can I add something?
Oh, yes.
Yeah.
Yes, please.
Yeah, good evening, everyone. Dr. Dolly, it was an excellent talk. I just want to add here, because once we talk about ART pregnancy, this is a very usual practice to see cesarean deliveries in such cases. So, I mean, since we are seeing a lot of ART deliveries to be conducted by cesarean, so I just want a comment from each one of you that, because we know it is not an indication, but the pressure from either side, from the maternal side as well as from the doctor, that we want a safe delivery. So what is the medico-legal catch on this? Patel, sir.
During panel discussion, we will cover.
Yeah, okay. Thank you, sir.
And I would like to comment on that previous question of ART pregnancy, how long you continue the progesterone. The best of both the worlds would be, and what many of us do practice rightly, is one, definitely progesterone till placental shift and the 12 weeks. But after that, the strict monitoring of the cervix, that is very much necessary, right from the cervical length, cervical direction, as well as the internal os. Once we see the monitor, especially after 14-16 weeks of pregnancy, if you start seeing some funneling, that is the right time that you have to intervene, counsel, progesterone versus the stage, everything you have to explain. But if you see that everything is fine, absolutely like any other normal pregnancy, you don't have to continue with the progesterone post 12 weeks. That is the standard practice.
Archana ma'am has joined in. Archana ma'am.
Can I add to this? Good evening, everybody. I've just joined.
Yes.
But
Yes.
that seems to be a very nice discussion going on. 2 points, I fully agree with the speaker who was speaking right now. Nobody can book you if everything is fine, the cervix is fine. Nobody can tell you that why you switched off the progesterone. That has to be documented. Second is the question of Dr. Manila, that all ART pregnancies are to be delivered by cesarean sections. Of course, the patient's psychology is always there, but whatever you write for cesarean section, basically documentation is the most important point. You just can't write in indication that it is an IVF pregnancy, therefore we did a cesarean section. There has to be a documented indication for that, and that is the most important point there. Because IVF pregnancies are also being delivered vaginally. That is also equally true.
Yes. Of
Yeah,
course, the
Sumitra
monitoring is
madam, that's
important.
what I wanted to say on this forum, that yes, vaginal delivery and cesarean section is not an indication here. So we all should promote vaginal deliveries in ART pregnancy. We do understand these patients are high-risk women, elderly, having a lot of complication. That's why they ended up into infertility. So my topic was here. I mean, I want to bring up this topic that yes, no, all patients should not be delivered by cesarean. We should give them a trial of labor, and if at all cesareans, then we should have a clear indication that has to be either maternal or obstetrics.
Yes.
Thank
So
you.
there should be some valid indication as far as maternal side or fetal side, and you can justify your cesarean section. But merely
Another
on the
thing
ground that it is IVF pregnancy and it is precious pregnancy cannot be the ground for cesarean section always.
Yes, every precious pregnancy is precious. You can't say precious pregnancy as an
Every
indication.
pregnancy is precious.
Another thing that I don't know if you people have already talked about it, is injection Proleotone depot that is being prescribed like anything. Unless and until indicated, it is not to be prescribed. That should be very clear take home today.
Yes.
Dr.
Previous
Archana Basil,
Proleotone
madam,
depot
wanted to
was
speak.
used very in a good number, but in between Proleotone depot was not that much used. Progesterone had taken the place, but again Proleotone depot has come in the market, and many of our Foxian friends prefer to go with Proleotone depot rather than to go with any other progesterone also.
Dr. Archana Basil wanted to speak something, sir.
Yes. But we can have our comments.
Good evening, ma'am.
Also. No issue.
No, it was a wonderful talk, good take-home
welcome.
message, Dolly. But only one thing I think Sir has said that we'll be talking in the panel discussion. As far as IVF and cesarean section is concerned, I think it's not hand in hand. If you counsel them well, few of them would deliver vaginally.
Yes.
So may I start the panel?
Oh yes. Oh yes.
So thank you, Dr. Dolly, for that excellent presentation. Really loved it, and your slides were really very clean and well made.
Thank you, ma'am.
So,
Thank you.
thank you. And thank you, Sumitra ma'am. Thank you, Alka ma'am. And thank you, Manisha Maheshwari ma'am, for being with us. I also thank Dr. Kavita, who's still here being a guest. And Dr. Jyoti, as you are still here, you may join in the panel if you wish. So I'm going to start the panel now.
Dr. Dolly, it was a wonderful presentation. Thanks and congratulations.
So, sir, we start the panel.
Oh, yes.
It's a reverse panel on legal issues in pregnancy and labor. Sir is the expert and I'm the coordinator, moderator, whatever you may call. Sir has not been formally introduced in this program. So I would like to formally introduce him as the consultant obstetrician gynecologist and medical legal counselor. He was Vice President FOGSI 2018, Organizing Secretary AICOG 2017, Chairperson Ethics and Medical Legal Committee FOGSI 2011 to 13, Honorary Secretary SOGO 2022 to 24, Organizing Chairperson MMCon 2018, Honorary Member National Inspection and Monitoring Committee, PNDT Act, Government of India 2015, Honorary Member State Supervisory Board, PNDT Committee, Gujarat 2005 to 9, President Ahmedabad Obstetric Gynec Society 2010 to 11, Honorary Member National Managing Body, Indian Red Cross Society 19 to 22, National President, National Medicos Organization 2016 to 18, President IMA Ahmedabad, Honorary Surgeon, Organizing Chairperson Vivekanand NMC Con. He, as already mentioned, has been going to the Northeast to give free service for 21 years. And he has been giving help to any obstetrician gynecologist needing it medico-legally, as he loved to say in his lectures, keep my card under your pillow and sleep peacefully. So, welcome, sir. And that's me, I've been introduced. We can all have a short video of sir. As he's standing for president, this is his simple appeal to everyone.
शुभं करोतु कल्याणं आरोग्यं सुखसम्पदम्.
Respected seniors and dear colleagues, serving Foxy for years together on this auspicious day, with folded hands and down head, I seek your guidance, blessings, and support to endorse my candidature for the post of Foxy President, year 2026, election year 2024. Consistently working for Foxy and trying to visit even a smaller societies and to assist our common Foxyian friends in any given situation, I have tried to serve Foxy. I assure to serve Foxy in the same way with the same zeal and enthusiasm. पथ का अंतिम लक्ष्य नहीं, सिंहासन चढ़ते जाना, लिए सभी को साथ, आगे है बढ़ते जाना.
So, this is our panel, and the topic is medico-legal problems in obstetrics and gynecology. We have two experts. The first expert is Dr. Archana Baser ma'am, who's a consultant obstetrician and gynecologist, director at Akash Hospital. She is a Guinness World Record holder, removed the largest uterine tumor. Many accolades to her. She was the Foxy Vice President 2020, organized the AICOG 2021 at Indore, Fellow Representative AIC-RCOG West Zone, Imaging Science Committee Chair, SAFOG, Chairperson of Foxy Imaging Science Committee 2015 to 17, Organizing Secretary ISAR 2016, and Managing Committee Member ISAR, IAG, and ICOG. Welcome, ma'am. We have Dr. Chandan Papadia ma'am, who's a senior obstetrician and gynecologist, been practicing more than 38 years, ex-president, State Obstetric and Gynec Association 2017 to 20, ex-president ISOPAB Indore, vice chairperson AICOG 2022 Indore, founder president IMS Indore, received Dr. S.K. Mukherjee Award in the year 2017, organizing chairman of Yuva Foxy Zonal Conference and ISOPAB Zonal Conference. He's organized several state conferences and has a special expertise in high-risk pregnancy and vaginal surgeries. Welcome, madam. Now I will invite my panelists as they come along in the program. I will not be introducing them all together. So the first, before we start the program officially, sir, I would ask you a simple question. Is this topic worth discussing?
Always, yes. Of course, yes. Because if you go with statistic of US, 78% gynecologists are shooed at least once in their lifetime. And 37% gynecologists are shooed for 3 times in lifetime. And if you go with India, then as far as total medico-legal consequences or total medico-legal cases are concerned, 29% of them are against gynecologists. So gynecologists rank first as far as medico-legal consequences are concerned. And that is why it is very much important to discuss as far as medico-legal issues concerned during our OBGYN practice.
Thank you, sir.
Yes.
So the first person we have is Dr. Sadhna Mehta. I will not be reading out the CV. I've just displayed it. She is the president of Indore Obstetric Gynec Society. And you can see she is attached to the Brahma Kumaris, practices meditation and yoga, and she loves music. So welcome, Dr. Sadhna Mehta, ma'am. And here's your question for you. Ma'am is here.
Yes, Sadhna madam. Is she
Sir,
there?
she's not here. No, she's not there.
Anybody
Dr.
from-
Jyoti, if you are there, would you ask? Dr. Jyoti?
Yes, ma'am.
Anyone from... Yeah,
Yes,
yeah,
ma'am.
if you would ask this question, Sadhna ma'am is not there.
Yes, actually, asking to sir is a little actually, while litigations are common related to pregnancy and labor, and any case related to this.
Naturally, as far as litigation in our obstetric patients are concerned, usually they are young patients and usually they come on foot. Of course, in few of the conditions they are brought in emergency, it is a different story. But in usual course, patient comes on foot and usually they are book patient. Of course, they few could be unbooked, but usually they are book patient. So expectation on part of patient and patient party is very much high. And naturally, we are dealing with two life, mother and fetus. So these are the conditions where if at all anything goes wrong, people are not mentally prepared to accept any complication or untoward outcome because they consider this to be a very physiological phenomena and not pathological one. So these are some reasons why these litigations are concerned related to pregnancy and labor. As far as case, there are so many cases which have filed against our gynecologist friend as far as pregnancy related complication or labor related complications are concerned. I would like to mention only one which recently happened in city of Ahmedabad only. It was pregnancy after ART treatment. So again, it was the topic of today's. Dolly has nicely covered the subject. So it was IVF pregnancy. Patient was very regular in her antenatal checkup. Every time sonography was done, and she was told that mild polyhydramnios means everything is fine. At 34 weeks of pregnancy, during routine antenatal checkup, a gynecologist came to know that it is a case of intrauterine fetal death. It was confirmed by sonography, and she was told that some good sonography with big machine is required. Patient had been there, and ultimately diagnosis was stamped that it is IUFD, and cesarean section was advised. So in this case, before cesarean section, all investigation, usually we go before major surgery, were advised. And out of those investigation, blood sugar came out to be 432. So it was never advised before. So not to advise blood sugar in antenatal period cannot be pardoned in court of law. So in this case, of course, case is still to be decided, but compensation of 2 crore is demanded by patient party. So as far as pregnancy or pregnancy related complications or labor related complications are concerned, patient or patient party may prefer litigation at any time.
Actually, this is the very happy moment for the patient and their relative, and they are having very high hopes about the delivery.
Yes, exactly.
And whenever something happens, they are not prepared for this also.
Yes, they are not mentally prepared.
And actually,
when they are book patient, they are coming regularly for antenatal checkup for all 9 months, and then something goes wrong during labor. then they are not mentally prepared to accept any untoward outcome.
And there are the relatives who are saying this is a very physiological phenomena. And in the old times, the guys are only conducting the
Yes,
delivery.
yes, exactly.
So why this doctor did some mistake? This is the.
Can I make a comment here?
Oh yes, welcome,
Yeah,
madam.
the thing is, I think we all discuss about that this should have been done, that should have been done, and patient, it's a physiological condition, yes, accepted. It's a physiological condition, and a healthy young woman, if she's pregnant, nobody would accept that she's going to die or her babies should die, and neither the doctors want. But should we not tell a little bit about the complications of pregnancy to the women? I'm just asking Dr. Patel, though, that at the beginning when you're booking or saying that it's a healthy situation, everyone is healthy, but still the pregnancy, no pregnancy is like any pregnancy can turn any point of time into a volcano. So
yes, we are going to discuss this question in succession, because somebody is going to ask this question. So it will be repetition. So at that time I will cover.
Okay.
Thank you, sir.
Yes.
Thank you, Archana ma'am. Thank you, Jyoti.
on
Dr.
this-
Shweta had to leave just now because of some emergency in her house. She said there is an emergency and I have to leave. So again, requesting someone from Indore, please take this question.
I'm taking this also. Which are the areas for litigation and which are the assisted obstetric situation which may lead to litigation?
So usually, as far as our obstetric practice is concerned, common allegation during litigations could be delayed in diagnosis or investigation not advised or properly that very patient is not managed. Say, for example, many times on delivery table during cesarean section, we come to know that it is adherent placenta. So in this type of situation, allegation could be delayed in diagnosis, wrong diagnosis, no diagnosis at all, or no proper consent taken, issue of staff, then infrastructure issue, unnecessary investigation. Many times now it is also one of the allegation that doctor advised so many investigations. So unnecessary investigation could be one of the area. Emergency service is not rendered properly. Many a time patient is brought to hospital and at that time doctor is not available at hospital, he is at home, and naturally staff will call and doctor will come to the hospital. But for any reason, if patient is not immediately attended, then this could be also one of the reason. Communication failure. Many a times this is also one more allegation that we were not communicated properly. We were not explained about all treatment plan and condition of the patient properly. Delayed in transfer. Many times if we have to transfer patient to higher center for any reason, then if it is not transferred well in time, it could be also one of the allegation. Complications related to pregnancy, complications related to delivery, complications related to instrumental delivery or surgery. These are also some more areas as far as litigation part is concerned. Congenital fetal anomalies. If we have missed during our pregnancy profile or this sonography, etc., and if baby delivers with congenital anomaly, it is also one of the major problem. Any complication, naturally, morbidity and or mortality as far as maternal part is concerned, as well as fetal part is concerned, is also one more area. And nowadays, one more allegation is overcharging or many times exorbitant charge against unexpected result. Patient has expectation of some favorable result and they are paying for that. And if something goes wrong, then there could be one more allegation that it was exorbitant charge, and even then we couldn't get good result. One more allegation in this type of situation is improper diagnosis of fetal distress also, or improper interpretation of CTG, improper application of instrument like forceps or vacuum, and some birth injuries. So these are the areas as far as litigation part is concerned. And very common allegation if we do not go with cesarean section well in time, then one allegation that cesarean section was not decided or not done well in time if something goes wrong. And if it is done, then there would be allegation that it was unnecessary. That so unnecessary cesarean section was done. So we are in a very tricky situation in this type of condition, because in court of law also we have to justify our decision whether to go for cesarean section or whether not to go for cesarean section.
Actually, most of the time when the baby is the IUGR or preterm, and they are not expected to pay for this NICU charges also. So the litigation part starts from there also.
Yes.
They're saying you have not told us. So as Archana madam rightly said, we are having in the healthy discussion in the 9 months only to in the guarded way we have to convey everything about the.
One more thing I would like to add here, we are talking about litigation thing and where we are likely to get litigation, but how to protect ourselves against this litigation? Are you going to be covering this?
Yes,
Or
yes, we will
along with
discuss.
the questions you are
Yes.
going to be
No,
dealing
no,
with
we
those
will at the end we will cover that also, how to prevent, and if at all we ended into this type of problem, how to get rid of it.
Yeah, because I think we don't have our like in some countries there are doctor held records and patient held records. As you said that there is over investigation, under investigation. But sometimes we don't know. The doctor might have advised the blood sugar or something and patient didn't get it done. And then ultimately they beat the drums from either side. You do
No, so this is
this,
non-compliance on part of patient.
I
Archana
think
madam.
it's important that somewhere we
Yes.
should have the notes
Yes,
copy or
exactly.
maybe the relevant where we know that this is a red flag, this patient
Yes.
might give a problem. We should keep a copy of the notes.
Yes, exactly. So whatever we advise as far as any investigation, and if patient doesn't get it done, then it becomes a contributory negligence on part of patient, and it becomes a good defense in our favor. But it should be well documented, and we should be in a position to prove it, that we had advised all these investigation well in time, but patient didn't get it done. So if we can prove in court of law, it is a good defense.
Thank you, sir. Thank you.
Yes.
Thank you, sir.
Yes.
Now we have Dr. Manik Panse, the president of Jabalpur Obstetric Gynec Society. And she loves going out for safaris and basically enjoying time with her family. So over to you, Manik ma'am.
Thank you, madam. My case is baby Ramya versus Dr. Aruna Reddy. Am I audible?
Yes, yes, you are audible.
Aruna Reddy, 1995, CTJ, 367 AP. Facts of the case: forceps delivery, delivered baby of 4.5 kg vaginally. Baby developed brachial palsy. Case was filed. Defense on the part of doctor: complicated case. Patient refused for consent for cesarean. Baby was getting asphyxiated. Inference held by the court: admitted at 6 a.m. Delivery started at 4 p.m. No investigation or sonography, no evidence that consent was refused. Allowed rupees 175 lakh. Where things went wrong?
So in this very case, it was a very famous case of baby Ramya. It was forceps delivery, deliver 4.5 kg baby vaginal. So when this type of big baby, 4.5 kg baby to deliver vaginally, it is not that easy task as far as vaginal delivery is concerned. So if at all we are planning to go with vaginal route, if everything is fine, but it should be well explained to the patient that it is big baby and this is the situation, and what could be the probable outcome or complication related to that. In this, cesarean section was advised and it was refused by patient. So when patient refuses, cesarean is indicated, any patient refuses to give consent, then it should be well documented. Here comes a role of negative consent. When patient is not ready to give consent, or say for example instrumental delivery, we have to intervene by forceps or vacuum, and patient is not giving consent. We have to go for cesarean section under asphyxia and patient is not giving consent. Then it should be well documented that patient has not given consent. Patient can give negative consent, but in few of the cases, it is also observed that patient is not ready to give negative consent also. So in this situation, we can have signature of any co-patient, any visitor of hospital, that it was explained before us to the patient and patient party, and cesarean section was indicated, but they didn't give consent. But in this situation, whomsoever we request to sign the document, that before them it was explained, a full detail of that very person who has signed the document should be with us. Because if at all it is needed, and it should be explained to them also when they sign the document, that if at all it is required in court of law, then you will be invited in court of law to give evidence that before you, in your presence, we had explained everything to the patient. So it is a role of negative consent. So
Sir,
it
I
should
would like to ask one question.
Yes.
It's okay in 1995, that is the year, you know. But nowadays, 4.5 kg, why should we give so much, such a long trial?
Agreed. I started with that only. If
Yeah.
at all we are going to get it delivered vaginally, then also it should be explained. A risk involved to deliver vaginally, because many a time patient or patient party will insist that doctor, let us try vaginally. So in this situation, we have to counsel patient and patient party well in advance that these are the possible complications related to vaginal delivery. Otherwise, usually in this era of CPA with baby of 4 or
No one does it.
4.5 kg, nobody will try to go for vaginal delivery. They will explain well in advance, and most probably it would be elective cesarean section only.
Sir, I would like to say something. If patient is not giving ready to give negative consent, and we are taking the consent of other attendant and persons, and at the time of the court call, if the attendant is not available, because they are all unknown person.
So that is why I mentioned we should have all the details of that very person who is signing the document, that before us it was explained and they refused to give consent.
But there should be one alternative. One is staff or hospital person and staff can give the consent.
Because of course we can have a signature of staff, but in court of law and part of prosecution, that could be argument that hospital staff was your staff, so it cannot be considered as the independent person. It becomes a party to hospital. So it is better to have a signature of third party, that is independent person. Any co-patient, any visitor of hospital, even any other relative of patient can also give consent. But in this situation, it is risky one, because relative may go hostile at any time.
And they will also not give the consent. Yes. There's a difficulty in that.
Yes.
Yes.
Sir, on OPD papers also we should write down high risk cases.
Yes,
high risk.
and
What are
copy
the
should
risks
be with us only, because whatever we do in our practice, not only pregnancy, labor, I would say any of our practice, we should be in a position to justify our action in court of law if at all we are faced any litigation. So if we can justify our action, if we can justify our treatment, then we are out of problem.
So we should, from very start, we should not say it is a low risk patient. It's a low risk patient for all, and we should write every details of investigations what we advise on the OPD paper. So patient, if they do or they don't do it, it's their own wish, and they're responsible for that. I think so.
Yes.
Sir, I would like to add something. When we were there in medical college, we used to have a system of having red labeled medical record or green labeled medical record. Red used to be for high risk and green used to be for normal risk. That should be uniformly practiced even in private practitioners.
So I really talk into so many of my lecture also. Whenever you are dealing with any high risk pregnancy case, say for example, patient is GDM or hypertensive disorders of pregnancy or multiple pregnancy. So whenever you are dealing with high risk pregnancy, a patient and relative of patient should be explained everything well in advance about this high risk elements. And if we are dealing with a serious patient, say for example, if it is a case of HELLP syndrome, many times patient is brought in in a condition of HELLP syndrome and we are dealing with, then relatives should be explained at each stage of our treatment, time by time. So if at all something goes wrong, they should be mentally prepared to face this situation. So in high-risk pregnancy cases, our role becomes very crucial as far as counseling and communication to the relatives are concerned.
Can I add something, sir, here?
Yes.
Sir, what I think, I mean, what Dr. Sunita said, that red and red flag, green flag, that's for the management purposes, it's good. Like, high risk patient requires more set of visits and thing. But medication can arise in low risk patients also, because low risk patients are unprepared for any complications. So as far as the litigation thing is concerned, I mean, we should have a third eye, like who are the patients who are more likely to get you into trouble. High risk patient, because you are more vigilant, parents and patients and their relatives are more vigilant. So they are at high risk and they will be identified and treated immediately. But the low risk patients are the one who are totally unprepared by us, are likely to get more into the litigation thing. That's what is, I think, my observation.
I fully agree. I fully agree to this.
Ma'am, I can add something. If a patient is coming into my OPD and she is continuously being treated for hypothyroidism and she has been labeled as a red labeled flagged paper, so mentally they are prepared that she is by and large a high risk patient, and she will have that in mind that I'll have to. Otherwise, at times they just wait for the delivery to happen in the PHC or maybe at some remote places, and they would not come. And in private practice, we usually don't label and flag these papers to be red labeled papers or green labeled papers.
See, I personally feel that no pregnancy is
Dr.
low risk.
We should have our own codes. Like we put with the pains. Some people will put the labels. That's very perfectly fine as far as the management is concerned. What a point I'm putting is for litigation, it's a different, a little bit of a different thing as well. We have to keep in mind not only the high risk are going to trouble you, the low risk can also trouble.
Yes, ma'am.
One thing I would also like to ask you, sir, that nowadays patients have become over smart. Today only is my emergency in a government hospital, and we had taken consent of a patient, high risk consent, that she had to give consent for cesarean section. So initially they gave it. Then after some time the patient disappeared. Then she came after a long time with all the consent struck off with a blue pen. So of course I made them write that they have done this job. But if I was not alert, because being in a government hospital where you deliver nearly 42 to 50 patients per day, it becomes really difficult. And then nowadays in government also this litigation thing is there. So how to avoid this?
Yes.
Because the patient has the papers.
When patient disappears from the hospital,
right, sir,
it is to be mentioned in that very case paper with the signature of co-patient. That on bed of that very patient.
The thing is that patients abscond with papers. That is what is the issue.
We can have fresh paper, no issue. Said this patient is not seen on her bed since 1 hour, 2 hours, 3 hours or so. And it should be well recorded and it should be communicated to the head of the unit, head of the department, or head of the institution. So we are
why I have got this thing here is that today it struck me that when we think that these uneducated or less educated patients can do this in the government, this can be done very well.
But one thing, once patient is absconded, fine. But when this patient comes again and you accept her to treat, because if we go legally, then whenever you accept any patient to treat, then it becomes a contract or implied contract between patient and yourself. You are offering your expert services and patient pays for that or patient promises to pay for that. So if patient is absconded, fine, that contract is over. But when patient comes again, and again if you accept her to treat, then at that point again new contract legally. Legally, it is new contract between patient and yourself. So you can have ground, of course, that she was advised cesarean section well in advance. Before this day, she didn't take it seriously. She was absconded from the hospital. It becomes a good defense in your favor. But it could not be all the defense, because second time when she comes again to your hospital, and once you get her admitted and you are treating, your responsibility remains the same as far as treatment part is concerned. But it should be well documented, because it shows that patient is not complying our advice, our instruction. So it becomes a good defense in our favor.
Good evening, sir.
Sir, excuse me, sir. Excuse me, sir. Excuse me. MC Patel, sir.
Yes, we go question by one.
We
by
have
one,
to
and
go.
at the end,
We have to go ahead, and
Yes.
we can take all extra questions at the end, sir.
Okay,
Otherwise, there'll
fine,
be a
fine.
lot of repetition, and the structured questions will go away.
Oh yes, oh yes.
So, sir, Dr. Deepti Gupta, who's the secretary of Jabalpur Society, she does embroidery and painting, as you can see. But she has sent me a message that she suddenly has guests in the house, requesting somebody from Jabalpur to please take this question.
Sure, madam.
Anyone from Jabalpur, please take this question.
Nanik madam, are you taking that or should I take
No,
the
no, you
question?
take. Rita, you take.
Okay, fine.
Okay. So this is a case, Nina Gupta versus Deep Nursing Home, 1996, CPC 116, Chandigarh. Facts of the case. Forceps delivery happened and intravesical fistula developed. Defense on part of the doctor occurred during the process. Inference held by court liable. Where thing went wrong?
So this is again very famous case of Nina Gupta. In forceps delivery, ultimately it went into intravesical fistula. So in this type of situation, again, counseling is very much important. Whenever we are going to go for forceps delivery, then we should explain well in advance that we are considering this and these are the probable complications. But as far as complication is concerned, complication per se is not negligence. It may occur, but once it occurs, it should be diagnosed well in time and it should be managed in a very efficient manner. So if you manage that complication way in which any prudent gynecologist would have managed, then you could be out of problem. But in this particular case, Nina Gupta versus Deep Nursing Home, this defense on part of doctor was that this injury occurred during process. But if at all it occurred during process, then it should be well explained to the patient after delivery that this has happened and this is the line of management in future as far as this intravesical fistula is concerned. But it was not explained. And after few days, patient came with leaking and this case was filed. So if at all complications happened, then post-delivery or in case of surgery, post-surgery, counseling is equally important. If at all you have encountered any complication and if you have dealt with accordingly, then if you have counsel, then it could be good defense in your favor.
Thank you, sir.
Yes.
Thank you, sir.
Yes.
Thank you, Dr. Richa. Now we have Sunita Wadhwani ma'am, who's the president of Ratlam Society. She's sent a really small CV. She's a lead assessor and master trainer in Manyata. And you can see her painting, gardening, and travels. A very, very talented person, Dr. Sunita. Over to you.
Yes, Sunita. So as far as her gardening is concerned, I am witness during my last visit at Ratlam. I had been to her house. She has maintained very beautiful garden.
Thank you, sir. Thank you very much.
Yes. And Sunita is known for good hospitality also.
Thank you, sir. Thank you very much. Always a
Yes.
pleasure having you here in Ratlam. And we
Yes.
at times forget that you are not from Ratlam. We consider you as part of Ratlam Obstetric and Gynec
Yes,
Society.
yes. I have visited Ratlam so many times.
Yes, sir. Yes, sir.
Yes.
And thank you very much, sir, for giving us this opportunity of being on this platform. And the question for today is, please discuss the birth injuries and litigations. Which injuries are more likely to cause litigations?
So as far as birth injuries are concerned, both part, maternal side as well as fetal side. And as far as maternal side is concerned, perineal laceration or anal sphincter injury. Usually these are the very major complications related to birth injury, or any lacerations, paraurethral or urethral injury or bladder injury, and ultimately ending into VVF or RVF, rupture of uterus, whether it is repairable or uterus is to be removed. Then these are some areas as far as these litigations are concerned. And as far as fetal part is concerned, so fetal asphyxia and birth asphyxia leading to some permanent ailments, etc., or Kifel hematoma, fracture, clavicle fracture, or a long bone fracture, Earth palsy, and CP in future, ultimately developing CP in future. Injury during breech delivery, whenever we are conducting breech delivery and some injury goes with baby, then at the time of cesarean section, sharp injury with knife to the body part of fetus is also one more area. And perinatal death of fetus is also one more area as far as litigation are concerned. But which injuries are very likely to cause litigation is which injuries which are having permanent liability. Then these are the cases. Say for example, Earth palsy or case of CP. Then these are the potential cases as far as litigation is concerned, and we should be very careful in this type of situation. Yes, next.
Thank you, sir.
Thank you, sir. Now we have Dr. Aditi Rathore, madam. She is a consultant Rathore Nursing Home at Ratlam, and traveling, adventure traveling is what she does. Over to you, Dr. Aditi.
Good evening, everybody. Thank you, sir, and thank you, Asha Jain ma'am, for the opportunity. So the question for sir is, what is negligence and what are the various types of negligence?
So in our curriculum during MBBS in forensic medicine, we were taught two words: act of omission and act of commission. So act of omission means not to do something which a reasonable prudent doctor would do. An act of commission means doing something which a reasonable prudent doctor would not do. Say for example, if it is a planned cesarean section and we have decided to go in a general anesthesia, usually we do not go, but if at all anesthesiologist has advised to go in a general anesthesia, and patient has come with full stomach. So naturally, any prudent anesthesiologist would not give general anesthesia on full stomach in elective surgery. If it is an emergency, we can explain to the patient and patient party, and we can take calculated risk is a different story. But if it is a planned surgery, and if we omit this type of thing, that omission, then it becomes a act of omission and it is a negligence. Same way, act of commission means doing something which reasonable prudent doctor would not do. Say for example, in case of just I mentioned about this cesarean section, but omission means say for example, giving injection of penicillin full dose without doing any negative test dose. So in this type of situation, naturally any prudent doctor would go for negative test dose and then only he will go for full dose. So if we omit something or if we commit something which is not expected as a prudent doctor, then it becomes a case of negligence. And just I mentioned prior also, as soon as we accept any patient to treat, then our legal duty starts at that point of time. At that point of time, once we accept the patient. And if there is any breach of that legal duty, and due to that very breach of legal duty, if patient suffers any damage, and our action, that is action of treating doctor, should be direct and proximate to cause that damage. So these are the ingredients as far as negligence is concerned. So legal duty, existence of that legal duty, that is once we accept the patient, and breach of that legal duty, damage suffered by patient, and direct and proximate action of doctor responsible for that damage. So if prosecution can prove all this, then it is proved that we were negligent in our dealing with the patient. But usually in court of law, it is very difficult to prove negligence against doctor. Because if we have treated any patient as per standard protocols, as per standard guideline, given in textbook, or as per practice prevailing in nearby medical college, or prevailing in peer groups, or as per expert. So if we have treated patient that way, then it becomes good defense in our favor. Yes, next.
So next we have Neha Saraf, sir. Dr. Neha Saraf, my dear friend, the adventurous biker cyclist. Over to you, Dr. Neha.
Thank you, ma'am. Thank you so much. Ma'am, before taking my question, I would like to thank you, Patel sir. Thank you, Asha ma'am. Thank you, Rekha ma'am, for making me a part of this. And special thanks to Asha ma'am for this lovely way of introducing us. A very different, very innovative idea, ma'am, liked by all. Thank you so much.
Thank you. Thank you. Actually, we should know you as persons and not just as, that's what I feel.
Yes, ma'am. This is being liked by everyone because by the end of the session, panelists को तो ऐसा होता है अच्छा जल्दी introduce करो, जल्दी panel खत्म करो, and it's like that. But this is so nice. Thank you, ma'am. So my question to you is, what do you feel? What is the importance of consent? I mean, is consent necessary in case of normal labor?
Yes. So naturally, important of consent is very much required because in one of the cases, that is C. Jaipal Reddy versus Padmini Velluri, in that very case, National Commission has very specifically mentioned that consent is not mere piece of paper where patient or patient party has to sign, but it is a very important document of your communication, of your counseling. So whatever you counsel, whatever you communicate to the patient, each and every point should be mentioned in that with consent paper, then patient has to sign. As far as our obstetric part is concerned, and normal labor or so. So is it necessary to go for consent in normal labor? Yes, because usually this is not tradition in India, because if we go with normal labor, fine, we do not go with any consent. But does it mean that process of this labor is physiological? And does it imply that patient knows each and every complications related to even normal labor? There's just I mentioned about birth injury, complete perineal tear, say for example. So does she know? So if she doesn't know all this, then it is the importance of taking consent even in case of normal labor also. So when you will take consent in this situation? So if it is your book patient, so previously it was also asked by somebody, so I am discussing that. So during your routine antenatal checkup, you can give a full paper set of this consent to the patient. In that very set, everything is explained about probable complications of pregnancy, probable complications of labor, and probable complications of instrumental delivery or some surgical intervention also. And it is available on FOXI website. So with three medical legal experts, Dr. Dilip Phalke from Pune, Dr. Nikhil Datar from Mumbai, and myself, Dr. MC Patel from Ahmedabad, we have prepared almost 30 different consent. And in those 30 different consent, there is consent for normal labor also. In that very consent, we have prepared that consent in two parts. Part one is Information. Information, again, we have 8 subheadings. Say, for example, name of procedure, labor, normal labor, meaning. What is meaning of normal labor? Without assisting anything, when patient delivers vaginally, naturally, it is a normal labor. Assisted labor. So that way we have prepared that consent. And if you hand over that consent paper to the patient during her antenatal checkup, patient may go through that consent, and on second visit you can get it signed. This is one procedure. If patient is brought in an emergency, then you can take consent on admission also, because whenever patient is in agony of labor pain, many times in court of law there is an argument on part of prosecution that patient was not in a sound mental condition, patient was in agony of labor pain, so whichever document patient has signed as a consent cannot be considered as a valid consent. So if we have taken consent in advance, then it has a special weightage in court of law as far as any law proceeding is concerned.
Thank you so much, sir.
Thank you, sir.
Yes.
Thank you, sir. Now we have Dr. Richa Dhiravani ma'am, who's the professor, who's past secretary, Jabalpur Obstetric Gynec Society. She's already asked a question, and this is her pastime and her hobby, spending time with the family. Beautiful kids. Over to you, Dr. Richa.
Yes, madam. Can you hear me? Am I audible?
Oh, yes, welcome.
Yes, yes,
welcome,
you are audible.
welcome, Richa.
Yes, thank you, sir. First of all, thank you, Dr. Asha ma'am, Dr. Patel sir, for giving the opportunity. Patel sir has always been the go-to person when it comes to medical legal. So what better opportunity to do a reverse panel with you, sir? First of all, I'd like to ask you, what is the importance of record and what is the importance of discharge card?
Yes. So as far as record is concerned, it is document of our treatment plan or treatment given to the patient. So whatever we have done for that very patient, it should be well documented, because in court of law, say for example, in an emergency, oxygen was given, but it is not recorded in our document, then it is as good as oxygen was not given. So whatever we have done for that very patient should be well documented, and it is importance of record. Say for example, what was done, nothing was neglected, and given treatment should be met with standard of common normal medical norms, or standard demanded by law, or standard demanded by ethics. And we should have all these records. Say for example, partogram, say for example, CTG. So it shows our consent to take utmost care of any of our patient during labor or so. During pregnancy, whichever investigation we have advised, it should also be documented that we had advised all this investigation and well in time. If patient do not get it done, then it becomes contributory negligence on part of patient. But if we can prove by our document that we had advised all this investigation, all this intervention, all this during labor, then it shows our consent and it becomes a good defense. As far as discharge card is concerned, again, it is a very important document, because at the time of discharge, whether it is normal delivery, whether it is instrumental delivery, whether it is delivery by cesarean section or so, but whatever we have done for that very patient, in brief, it should be mentioned in discharge card. And very important part is instruction. Instruction to be given to the patient at the time of discharge. Say, for example, diet to be taken, medicine to be taken, exercise, follow-up, and some references. Because this is very important part, and I would like to mention one case which happened in state of Tamil Nadu. It was a premature delivery, and baby was admitted in NICU. But during admission, or at the time of discharge, because in due course baby was discharged also, but at the time of discharge also, NICU people didn't advise parents to have opinion from ophthalmologist to rule out retinopathy due to prematurity. And ultimately, in due course, baby went blind. Case was fine. And case was decided against hospital and this NICU people. And compensation of 1.8 crore was awarded in favor of patient. It was happened in state of Tamil Nadu, and it was in government hospital only. So 1.73 crore was to be paid by government of Tamil Nadu and rest of the amount by NICU doctors. In this party, luckily, gynecologists were not made party. So at the time of discharge, it is very important to mention each and every important point in discharge.
Sir, I would like to also ask you, what's your take on digital record keeping?
Yes, you can have a digital record also, but when you discharge patient, naturally you will give copy of discharge card to the patient. Na? Whether it is physical copy or
record?
Whether it is physical copy or whether you transfer all those record to the patient virtually also in her mobile or on her email, fine. If patient is literate and if he is this mobile savvy or this email savvy, then you can transfer all those records in that media also. But patient should be communicated well at the time of discharge.
Thank you.
Thank you, sir. So we need to be a little fast because we
Yes.
have a lot of panelists left.
Yes.
Dr. Anupama Dave has probably not joined.
No, she has not joined.
So she does embroidery and painting. So these are her paintings that you see here, sir.
Yes.
So I would request somebody from Indore, please take this question. Dr. Manila,
Yeah,
are you
ma'am.
there?
Yes,
Would you
ma'am.
please take this?
Okay, yeah. To sir, patient admitted with labor pain. She was in good health at time of admission. No satisfactory progress. LSCS was advised. Patient and relatives were reluctant to give consent. Doctor was constrained due to non-cooperation from the patient side and empathetically warned the attendants, including the patient, either to consent for cesarean section or to take the patient to any other hospital. So after 1 hour, attendants gave consent for LSCS, but asking for guarantee of mother and baby. What to do? So this is a very common scenario we come
Yes,
across.
common scenario.
Yeah.
So first, when you advise for cesarean section and patient were not ready to give consent, so we discussed prior also, here comes role of negative consent. So you will have to mention that patient is not ready to give consent and have a signature that we were explaining about importance of cesarean section. Cesarean section is indicated in that very point of time, but we are not giving consent. If patient or patient party do not give consent, that just I mentioned prior also, any person from hospital, co-patient or visitor of hospital can sign the document. Because when
Dr.
patient
Manila,
and
take
patient
the
party-
question forward. We
Yeah.
have more of it.
Okay. All right. LSCS was performed, sir. Asphyxiated baby with very low Apgar delivered. Had convulsions also after some time. Obviously, the baby was intubated and shifted to NICU. Now, attendants now blaming the doctors, saying that false hope of vaginal delivery was given, wrong medications were given, fetal heart was not checked during the labor. One injection was administered, which stopped the pain for some time. So that is very common, and then created situations such that the complaint was compelled to give consent for lower segment cesarean delivery. So it is.
These
Yeah.
are very common allegations.
Yes.
False hope of normal delivery. Naturally, whenever we admit any patient and we go for a trial for normal labor, then it is fine. But at the time of admission, we have to counsel patient well. Patient and patient party, whosoever is with patient, that we are trying our level best as far as normal vaginal delivery is concerned. But if at all something goes wrong, fetal asphyxia or maternal exhaustion or so, then we may have to go for intervention like instrumental delivery or for cesarean section. So at the time of admission only, patient should be well counseled and no false hope of normal delivery 100%. So it should be very clear. Wrong medicine were given, then they will have to prove that whichever medicine we give, because whenever we give all the records to the patient or in court of law, then everything is mentioned which medicine we have given. So they will have to prove that whether those medicine were false. False means it was not required and given, or which medicine which was required and not given. So that is burden of proof on their shoulder to prove. And as far as fetal heart was not checked. So whenever we check fetal heart, we mention in our record that fetal heart 146 per minute, regular, etc. If we have CTG monitoring, then print of CTG is very much in our favor. Partogram. So these are all some evidences which we can prove that we have taken utmost care as far as fetal heart part is concerned. And this is a very wrong allegation and usual allegation that some injection was given and then pain was stopped to create that now cesarean section is needed. So this is very common allegation, but in court of law, all this they will have to prove. So burden of proof is on their shoulders, so nothing to worry in this type
So
of
I
situation.
think the doctor would be saved in this case.
Yes, yes. We have to show all with our documentation and record that we have taken utmost care of that very patient as per standard medical norms, way in which any prudent gynecologist would have taken. Say, for example, this patient was not with that very gynecologist, and that patient would have been to some another gynecologist. What he would have done? Same way, if he or she has done, then they are out of problem.
Dr. Asha, I know we are getting short of time, but I just want to add on here that what I am practicing over years, that we give a written consent form, as sir mentioned, over WhatsApp to all the patient. That means digitally we know that it has been delivered, and when they come back, we get a signed signature done that they have read and understood it very clearly. So every damn thing is written that on that 4 papers, that the risk of asphyxia, the risk of doing emergency cesarean section is there. So if the patient are well explained, then there are less chances of litigation.
So in a consent which we have prepared on which is available on Foxy website also for normal labor, each and every point just you mentioned we have covered in that consent.
Thank you, sir.
Yes.
Is it given in Hindi also, sir?
No, it is in English.
Sir,
But
what
I have requested so many our friends in Hindi build that all those consents should be translated in Hindi, because in Maharashtra they have translated in Marathi. In Karnataka they have.
Sir, if I get through my election, I'll do it for you for sure.
Okay.
Sir, we had made it in Hindi and English as well, and we send it on both the language to the patient so that they can't say that they don't understand it.
So, sir, next we have Dr. Aradhana with us.
Manila ma'am, could you share it in the WhatsApp group?
Yeah, definitely. I will share it.
Consent.
So, sir has made
Only 1 minute. Only 1 minute. If you have prepared consent, I mean translated in Hindi, please send it to me. I will go through. And as far as legal part is concerned, I will check it. And if it is okay, then it can be available to all other Foxian friends also working in Hindi language states.
It will be very useful, yes, sir.
Yes.
But English, most of patients, they don't understand it. And we have to change.
But in this situation, if you explain in a language which patient can understand, and whether it is printed in English, then at the end of that concern, you will go with writing. If patient writes by answer, it's fine. Other you can also write that whatever mentioned above was explained to us in language which we could understand. And if patient signs, then it is presumed by law that whatever written above was explained to the patient, and then after patient has signed the document.
Yes, we can write also in our words also in their language, and we can sign. And we should have the witness of the sign, patient sign and witness.
Yes. One witness in favor of patient, one witness in favor of hospital.
Yes.
And doctor should also sign the consent.
Yeah.
Correct.
Either the doctor or consulting doctor, either of them.
Yes.
Thank you.
So, sir, we have Dr. Aradhana.
Yes,
and
welcome,
she's
Aradhana.
a state level swimmer. That is the biggest thing I wanted to tell. She has so many prizes in swimming, so many prizes. And she has IVF centers in Bhopal and Delhi. She's a singer. She's also a choreographer. So she does a lot of choreographing, but the new thing was the swimming. So over to you, Dr. Aradhna.
Thank
So
you, ma'am.
I am very much agree. She's good singer. I have heard so many times during our international tour of Egypt.
Thank you, sir,
Yes,
and thanks
yes.
for inviting me. And first
Yes.
of all, wish you best of luck from
Yes.
my side. And I know you will be the winner, but still
Thank you.
we always wish. From my side, and
So, Dr. Aradhna, this is a continuation of the last case.
yes. So, sir, we all know that cerebral palsy can occur later also, and it's not always necessary that it is a process of delivery. It could be, congenital also. It could be in womb also, and it could arise later also. If the baby is saved, and either it is a difficult delivery or not, that is a different issue. And but develop cerebral palsy, and now the attendant filed the case against the doctor. And there are two things immediately. If they find it like within few months or something like that, or later on, after a few years, then how to deal such situations, and how to counsel such attendants, and how to handle the litigation.
Yes.
So these are the
So,
questions really.
in this situation, if it is developed later on, then they will have to prove that whatever happened as far as cerebral palsy part is concerned, it was due to mismanaged labor or mismanaged pregnancy. So the burden of proof will be on their shoulder. Our part, that is a defense on our part, we should have a good record as far as our care taken during pregnancy and during labor is concerned. So if we have conducted that very labor as per standard medical norms, then we could be out of problem as far as cerebral palsy part is concerned.
Sir, actually, I have had one experience of this thing. I want to
Yes.
discuss. One of my
Yes.
patients, she had come to me, and that time his son was around 16 years. So last around 2 years back, and she said that when he was 5 years, he suddenly became unconscious in his school, and he was told that he is having some problem with the brain. She asked me, "Madam, is it a delivery complication? क्योंकि ये forceps delivery थी." So I was really surprised, like after 5 years, and suddenly something happened. I asked what doctor said, what was the diagnosis. So she said he is having a brain tumor. So I mean,
Whatever happens, they will always
they
communicate
always
with the
blame to the
treatment
doctor
given in
when
past.
delivery, and this is really, I thought I don't know what to answer. What to say.
Yes, it is a very common allegation. But we can save ourselves by a good record. Whatever we have done with that very patient, as per standard norms, it can prove as per standard protocol.
So I
Then we are
asked
out
her,
of
how
problem.
could brain tumor can occur because of some positive delivery?
One thing I would like to add, there are so many causes of cerebral palsy apart from the labor trauma. It can be any fever in the entity that can release cytokine.
It could be like rubella, it could be a chicken pox. They can also cause a cerebral palsy. So you can't blame every time to the delivery process.
Yes, the 10% cases related to labor. Other entity causes and other causes we can see for that.
Thank you, sir. Taking the program forward, we have Dr. Brajbala ma'am. She is the immediate past president of Indore Society, and she's going for Environmental Health Committee, FOXY, and you can see her love for the environment.
Yes.
So she loves.
So she is the right candidate for this committee.
Dancing. She loves traveling, gardening, and plantation. And I see some weird fruits which I think I'll come and sample in Indore. So over to you, Brajbala ma'am.
Thank you. Good evening. And first of all, I would like to thank IMC Patel sir and Asha Jain madam, and I'm associated with sir almost 2 decades now. And my daughter got her PG from Gujarat only, and sir is always supporting. So very best of luck, sir. And we are always having your support for everything. Whenever we are in trouble, we used to call you, and you are
Yes.
always helping. So my question is that a 32-year-old primary full term admitted with labor pains, and there was no significant past medical history. And with the labor progress, ARM was done and Liker was clear. But suddenly patient had arrest and there was no pulse, no BP was recordable. So it was suspected amniotic fluid embolism. Luckily, patient was in good setup. There was ICU, she was intubated. And so now what should be done? Should LSCS be done immediately as fetal hearts were normal, or patient should be shifted to ICU or other higher center? So this is very tricky situation when patient is in labor and there is maternal collapse, what to do, sir? So please guide us on.
So in this situation, you have to judge the situation that each patient in a position to be shifted, hemodynamically patient should be stable, then only you can think for transferring patient to any other center. Otherwise, you can very well manage that very patient at your hospital also. But in this situation, if you involve any other professional colleague, whether a senior gynecologist or physician or so, then it shows your consent that you have taken utmost care of your patient. If patient is in a position to transfer, then naturally you can transfer patient. But in this situation, you will escort that very patient in the same ambulance with IV line on, oxygen cylinder or emergency drugs, etc., so that we can manage patient on the way also if at all any other accident happens. So that way we have to manage.
So, sir, if facility is available there and multidisciplinary team is there, so with the consent of attendant, we can take her there.
Yes,
only.
very well. I mentioned that also. If we
Yes.
are competent enough to deal with the situation, and if we have all the facilities, then we can manage that very case patient at our level also. We can involve other people to share the responsibility, and it shows that you have taken utmost care. So you can manage.
So just
Sir,
want
actually,
to
the
check that
guidelines
started-
are that if there is maternal collapse, you need to take out the baby.
Yes.
That is the guideline, and there is no guideline that you should shift in that condition. The guideline is that after 4 minutes, you just take out the baby, and many a times the mother will improve once the baby is out. That is the critical care in obstetrics
So
guideline.
you mentioned about sudden obstetric collapse. So
Yeah.
in case of sudden obstetric collapse, and many times we may call it perimortem cesarean section.
Yes.
If patient is almost
Resuscitative
gone.
hysterectomy.
And I would like to mention one incidence of state of Madhya Pradesh only. In Rewa, our own Foxian friend, Dr. Binu Kushwaha, she went with this postmortem, peripartum cesarean section, and luckily baby and mother both were saved. But this is very, very difficult decision to be taken by any gynecologist, and many times patient's relative may not be convinced after, say for example, if patient couldn't be saved, baby is saved, many times both cannot be saved, so it becomes very difficult, and this is a very quick decision and quick action to be performed. So
Sir, as per the guidelines today, you need to see the watch when the patient goes into collapse, and
Yes.
at 4 minutes you need to take out the baby.
Yes. So
Because
within
only that way you will save the baby.
Yes, within three to 4 minutes, if you can deliver baby, then it will be good. And pregnancy, if it is more than 24 weeks, otherwise, if it is less than 24 weeks, then it is
Obviously.
not at all indicated, not at all it is going to be beneficial. But if it is more than 24 weeks, and if we deliver baby immediately within 3-4 minutes, and at the same time, one point of caution, CPR action should be continuous at that time also.
Yes.
When
Yes,
you
yes,
are
sir.
dealing with cesarean section, then CPR should be continued by anesthesiologist or any other colleague. So in this situation, but I would like to mention that at that point of time. Any important relative you can call inside when you are doing all these things, and you can explain that this has happened and this is the only way to save her. We are trying our level best, anything may happen. Because once you have explained this during that process also, then it will be good in your defense. Otherwise, if you have not mentioned anything to any of relative, and after this mishap happened, when you explain that this happened, we tried our level best, but we couldn't save patient or baby, it will be very difficult to convince them. So this is one part you should
I
keep
have
in
done
mind.
once in a case of hepatic coma. The patient hepatic coma, and she died. I mean, suddenly she became pulseless, BP-less, and then we shifted to the OT when I was in Banaras in the Heritage Hospital. And that time we did immediate cesarean, but we could not save the baby. And
It
obviously,
happens. It
she died.
happens, but
they didn't. I mean, the attendants were so well counseled that nothing. They have not created any issue. So I
Sir, one thing I want to add. One thing I want to add, can it be done without taking the consent of cesarean section?
Yes,
Because
yes. In any emergency situation, no
Without
consent is required. Whatever you do to save life of patient, if it is immediate necessary to save life of patient, no consent is required. But
yes,
burden of proof is on your shoulder to prove that it was dial emergency, and to whatever you did, it was to save life of patient. So with your record, with your documentation, you will have to prove that it was dial emergency.
Second thing, we can do it the same place where the patient is there, because we need to shift in the OT and take care.
No. Wherever patient is there, patient is in labor room, on labor table only, you have to go with. Because if you have to finish within 3-4 minutes, then you have no time to sit patient. No anesthesia required. Patient is already in collapse. So there won't be bleeding also. And with very quick, with one incision, you will open abdomen, with one incision, and it could be classical one. You will open uterus and you will deliver baby. So it should be as fast as possible. To
Same
have
place.
favorable result.
Yes, same place, same bed.
You are muted, madam. Madam, you need to unmute. Asha, madam.
Asha, ma'am, you're muted.
Me too.
So sorry. So we have Dr. Kaveri, past secretary of Jabalpur Society. She loves traveling and dancing, but she didn't share photos with me. So I'm sorry for that.
No
And
issues,
over
ma'am.
to you, Dr. Kaveri.
First of all, I am very much thankful to Patel sir, because after COVID time, now again we are on the same platform with the same motive. And last time also we joined for this medical classes only, and I'm really thankful that sir is chasing for the presidentship, and he should win, because we want people like you from Jabalpur. We really love you, sir, because a lot of people, whenever we are in the soup and we think what should be done, we just think Patel sir ko phone laga ke puchte hain. You must be getting calls.
I am always your assistance.
Thank you so much. And Asha Jain, madam, you are really a wonderful lady. You always keep we people in your good books that yes, where is the something new happening? Yes, I am there, and you just join us. So thank you for this wonderful academic session. So I just want to go ahead with this same patient where we couldn't dare to go for the cesarean, and this patient immediately expired. Then what should be done in this situation? Because thereafter, when you are trying to shift this patient to the nearest tertiary center or with a PPW, positive pressure respiration and all, because you have not enough facility, or you are not able to dare, or you don't have any such situation that, okay, you are going to handle such patient, and you are shifting the patient, and during shifting, the patient is getting expired in the ambulance. Unfortunately, it is the situation that the relatives, they are now coming back with the dead body, and now they want to create nuisance in the hospital that you have not referred in timely. And in such situation, what we should do, whom we should call for our help? First thing.
So
Second,
in this situation, first is resuscitation. We have to try our level best as far as resuscitation part is concerned. And in this situation, if anesthesiologist is nearby, then he is the best person to manage this patient. And in spite of all our efforts, if patient is expired, we couldn't save, then now here comes a role to declare bad news. And as far as declaration of bad news is concerned, before we declare, we should have a very quick words with our staff, because it is very important that all our staff should also speak in the same direction. Because many times what happens, relative will ask some of our staff what happened, and she will tell something. They will ask to another staff and she will tell something else. So in this situation,
Excuse me, sir.
yes.
Corona people has said that the session will end at 8:30, so we need to be really fast. We have 2 panelists left.
Okay, very quickly.
And it's only 5 minutes are remaining.
Yes. So in this situation, we will have to manage that very case as far as declaration of bad news is concerned. So some senior person should be there to declare, or the head of the team as far as this management is concerned. We can ask a member of RUST team.
FIR can be lodged against the doctor in such situation?
Yes. FIR can be lodged in any
And can we demand for the postmortems?
Then yes. Postmortem is always advisable, because whatever happened in 4 wall of operation theatre or labor room, and when there is no access to relative, then it is a common allegation that doctor didn't allow us, etc. So it is always better. So call senior people or member of RUST team, they will be at your rescue, and inform police. And once you inform police, custody of dead body will be taken by police, and they will send body for postmortem examination. And if postmortem examination is done, cause of death is given by postmortem a person who has done postmortem examination, it will be in your favor. So it is always better to advise postmortem. Many a time relative will give in a writing also, we do not want to go for postmortem examination, and we have no objection against anybody, any doctor, any hospital staff, etc. But if at all something goes wrong in court of law, then it doesn't give you any immunity. This type of writing has no immunity. So always to go for postmortem. Once you inform police, that is up to police to talk to a patient party for this postmortem examination also.
Thank you, sir. Now we have Monica ma'am. She's going for perinatology committee. We all know her. She loves traveling, teaching, and making friends. So over to you, Dr. Monica.
Thank you for kind involvement, Patel sir and Asha ma'am. Wish you all the best in your endeavors.
Thank you.
Always pray for your good health and happiness and success.
Thank
Sir,
you.
my patient is an average built Gravida 2 Para 1. She had a planned cesarean section which went uneventfully. There was a smooth intra-op period and post-op period, but she was to be discharged on 4th post-op day, and on 3rd post-op day, this patient was taken for a check dress. There she suddenly collapsed, became cyanosed. Resuscitation was started, but she could not be revived, and she was declared dead. The probable cause of death was stated as pulmonary embolism. Now there was a huge, hangama in the hospital. So how do we deal with this situation when the attendants have started creating nuisance?
Yes, same type of incidents happened in city of Ahmedabad only. And on 3rd post-op day during dressing, it was happened, and relative made some mischief also and some damage to the hospital also. But in Ahmedabad, we have RUST team, and Ahmedabad is a big city, so we have RUST team in each and every area. In that very area, doctor put message in RUST team that it is an emergency, please rush to the hospital. And you won't believe, within half an hour or so, almost 100 gynecologists were there at that very hospital, and this damage was prevented. Saved rather. Police was informed, and relative were not ready to go for postmortem examination in this situation. And the police informed magistrate also. Magistrate came. It was night time, and magistrate take a statements from relative, and relative gave statement before that magistrate that we have no complaint against hospital, we have no complaint against doctor, we do not want to go file any case, we do not want to go for postmortem examination. And with this, our doctor friend was saved. So here
Sir,
comes
we
a
have
very
1 minute left. We
Yes.
have 1 minute left. Dr.
Yes.
Manila, over
Yeah.
to you for the last question.
Yeah. So in continuation with that, against whom in such case medico-legal complaint can be lodged and where
Complaint can be lodged against anybody, treating doctor, assistant doctor, staff. They can made party to anybody. But whomsoever they made party, they will have to prove in court of law on part of prosecution.
Okay.
So
And
in
where?
that unity is strength. Yes,
Yeah.
sir, and Asha ma'am.
Correct.
Actually,
Where? Next question,
Where
Dr.
can
Manila.
yeah. So sir, where can the complaint can be
So
lodged?
if they are interested for money part, that is a compensation, then they will prefer under CPA or civil, or they may prefer criminal cases also in police station or directly in the court, in Human Rights Commission, government, our National Medical Commission also. And if it is happened in a government hospital, they may ask for departmental inquiry also. So they may complain in any forum. It is available for them, but they will have to prove all this litigations part is concerned.
Sir,
Thank you,
now
sir.
it is
Yes.
said that now I think the Supreme Court judgment or something, that doctor cannot be put on the criminal dharas like that.
So, there were guidelines given during famous case of Jacob Matthews versus State of Punjab, which was decided in Supreme Court in 2005. And Supreme Court came up with 3 guidelines. So, first guideline was there should be prima facie case of negligence against treating doctor. So, what investigating officer will do? All the papers of treatment given, statement on part of patient party, statement of doctor, statement of hospital staff, and he will send all those papers in nearby medical college department, in respective department, and they will seek for opinion from medical department. Very simple question they will put: is there any prima facie negligence on part of treating doctor? If a report comes that it doesn't seem any prima facie negligence on part of treating doctor, then criminal case cannot be lodged or file is closed at that point of time. If there is a opinion that it seems to be prima facie negligence on
Hello.
part of doctor, then case will be filed
है ना
and doctor
मेरे
can be
पीछे पास
arrested
में
if it is 304A.
चंपा को भेज दो ना
Bail can be given at police station
हाँ
level.
हाँ हाँ
If it is 304, then bail can be availed before honorable court. But in this situation, again, burden of proof on shoulder of prosecution, that on patient party to prove that patient was negligence in treating the patient. So hopefully we have covered many important points as far as pregnancy and labor part is concerned. So thank you very much all the panelists and expert Dr. Chandan madam and Dr. Archana Bashir madam for their expert inputs. And due to paucity of time, we will have to wind it up. But again, I would like to appeal to nominate candidature of Asha Jain for Food and Drug Committee, Dr. Monica for Perinatology Committee, and Dr. Braj Bala for Environmental Committee, and for myself for President Foxy in month of May. You will have to nominate our candidature, and in month of August from 1st to 10 for me you will have to vote, and from 15 to 30 vote for Monica, for Asha Jain, and for Braj Bala. Thank you very much.
Thank you, sir. We
Thank
wish
you,
you
sir.
good luck.
Thank you, sir. Thank you, everyone. I'm sorry I had to hurry the proceedings. I'm really sorry, but I really have no option. So
But
it's been
you are
great
still
knowing everyone.
You are
But
perfectly
whatever time we had, it was good discussion. We have utilized our time given.
yes, ma'am. And we are still online. That is good.
Yes.
Thank you, sir. Best
I
wishes.
really feel
Okay,
like,
thank
you
you,
know,
madam.
this
Thank
is
you.
like my family. Namaskar. Good
We are
night.
waiting for part
कल
2.
की वसंत पंचमी की शुभकामनाएं.
Absolutely, ma'am.
Thank you,
Thank you
Asha
so
madam.
much.
And all the best
Thank you,
wishes.
sir.
Sir, all the best wishes.
You're muted, Teeth.
Thank you.
Thank you.
You're
Thank
muted,
you, ma'am.
Tirth.
Thank you. Thank you. Thank you.
Thank you.
Thank you, Asha Di. Thank you,
Yes.
Dr. Monica. Best wishes, Dr. Asha. Best wishes, and Bridgely. Best wishes.
Thank you so
And of
much.
course, thank you so much for giving me
Dolly,
the
your
Dolly,
your
ma'am,
talk was
your talk
excellent.
was lovely. Lovely talk.
Thank you. Thank
You
you.
covered everything, Dolly.
Thank you so much.
Tirth, you are muted.
All the
Tirth
best.
Shah, Corona, you are muted.
Thank you.
Thank
Yeah,
you.
want to
Yes.
say something and end the session.
Yes.
Okay, ma'am. Okay, ma'am. I am ending this session. Okay, ma'am. Thank
Dr.
you.
Dolly, I'll
Thank
call you in a minute.
Thank you, Corona
Yeah,
people. I
sure.
would like to mention, thank you, Corona people, and Tirth in particular.
Thank you so much, sir.
Because Corona is
And right
with
now, I am
us,
ending this session.
Yes.
Thank you. Thank you.
As far as educational support is concerned, Corona is with us since long,
Thank you, Corona.
and we are disturbing Tirth many times as far as fire is concerned. You do this, you do that, but Tirth is kind enough with us to cooperate us. So thank you, Tirth, for that also.
Thank you so much, sir. Thank you.
Good night, everyone.
Thank you. Good night,
All
everyone.
the best, ma'am. All the best.
Thank you.
Okay,
Thank you.
thank you very much.
Bye.
Bye. Bye, sir.